What are the right anterolateral mini thoracotomy procedures can be done, and what are the sternotomy procedures can be done? Lesion appropriate for anterolateral mini thoracotomies are mitral valve replacement, tricuspid replacement, myxoma excision, ASD, PFO, and atrial fibrillation. But for aortic stenosis, you have to do the mini sternotomy. Procedures possible: mitral valve and tricuspid valve repair or replacement, excisions, and corrective surgeries. AV replacement or repairs, ascending aorta replacements. CP bypass cannula, if you look for, femoral venous and arterial cannula is required. Femoral or direct cannula can be done. Aortic cross clamp techniques, endoclamp balloon by a femoral arterial cannula, direct aortic cross clamp can be done. Direct aortic cross clamp can be done here. Robotic cardiac surgeries was first introduced in 1997 using simple voice-activated robot. Currently, 3D generation DA Vinci has come, and which is really going to help us in many ways. Surgical robots provides high-resolution 3D imaging, movement scaling, magnification of surgical field are tenfolds. Options of dual console for training. Limitations are the cost. Now, if you look for the AF ablation surgeries, ways to achieve surgical ablation, bilateral beds is required, incision with or without CP bypass, bipolar radiofrequency techniques, hybrid approach, surgical and percutaneous, endocardial catheter ablation by surgeon and cardiologist. Surgical approach, rhythm restoration is high as 93%. Now, minimally invasive video-assisted thoracoscopic surgeries has introduced by Carpenter and colleagues in 1996. Cardiac surgery performed by a right anterolateral video-assisted thoracoscopic incision with accessory ports. Indications are mitral and tricuspid valve repair replacement. Incision is less than 4 centimeter. Resection of myxoma right and left can be done. ASD PFO closure can be done with this. AF ablation can be done, and CP bypass femoral venous and arterial cannula is needed. Now, minimally access aortic valve replacements, upper mini sternotomy is required. AV replacement or repair can be done. Ascending aorta replacement can be done. CP bypass femoral or direct cannula is required. Now, this is a teamwork. One person cannot do it. Perfusionist, anesthesiologist, surgeons, and nursing staff is needed. Anesthesiologist points to keep it in mind are: we will need one lung ventilation, we will need cerebral oximetry, we will need large bore jugular venous access, and advanced skill in TOE. For perfusionist, points to remember are: peripheral cannula placement to be taken care. This can be displaced. Use of vacuum to assist venous drainage can cause airlock, hemolysis, and clamping. Method used for aortic occlusion and aortic clamping: endo balloon placement, because it might hamper the cerebral oxygen saturation or coronary circulation. Use of carbon dioxide to flood the surgical field, as de-airing is difficult in this kind of the scene. Advantages of minimally invasive mitral valve surgeries: safe and effective, cosmetically acceptable, suited for ERAS protocol. No significant difference in mortality as compared to conventional approach, these people are saying. So limitations are patient selection, elderly frail patient, and patients with comorbidities. Anesthesia for minimally invasive mitral valve surgeries, preoperative assessments. Apart from history, examination, and investigations, ECG, transthoracic echocardiography, transesophageal echocardiography, coronary angiography, PFT, CT to assess the arterial tree. Pre-medications, pros and cons to be weighed. Follow ERAS protocol, that will be better. All cardiac drugs to be managed as conventional. Monitoring, Standard monitoring, depth of anesthesia, cerebral oximetry, displacement of endoballoon can lead to unilateral hypoperfusion, bilateral cerebral venous desaturation, external defibrillation, PADS, pediatric, invasive arterial pressure monitoring, CVP monitoring, temperature, AVG, and electrolytes has to be done. All these things are going to be discussed in detail by coming speakers. So this is just the gist or introduction to these procedures. Induction and maintenance of anesthesia, pre-oxygenation, short-acting opioids with propofol, long-acting neuromuscular blocking agents, rocuronium and vacuronium, double lumen endobronchial tube, one lung ventilation, single lumen tube with bronchial blocker can also be used. Maintenance with volatile agent or propofol infusion, maintain temperature is must. Intraoperative esophageal endoscopy is required. Assessment of mitral valve, how we are going to do it. We need to do annular measurements. We need to do the anterior leaflet length, intertrigonal distance, SAM for mitral anterior leaflet after repair. Absolute and relative contraindication to minimally invasive mitral valve surgeries. Absolute contraindications are aneurysm of ascending aorta more than 40 millimeter, no defined sinotubular junction, aortic regurgitation more than moderate, inability to use tracheoesophageal echocardiography, transesophageal echocardiography, and mobile aortic atheroma. Relative contraindications are pectus excavatum, chest deformities. It is difficult to do the procedure. Pleural adhesions, history of chest trauma, rib fractures, previous radiotherapy, redo surgeries, morbid obesity, aortic atheromatous plaque, extreme mitral annular calcification. Vascular access to be taken, SVC and IVC cannulation inserted by a femoral vein, heparin before cannulation. Conduct of surgery, you have to keep these points in your mind. Padding on pressure points are must. Right arm. Avoid excessive traction on the brachial plexus. Arterial dissection and hemolysis can occur. Correct placement of endoballoon. Needs expertise, confirm with transesophageal echocardiography. During surgery, cerebral oximetry, cerebral blood flow monitoring is needed. Surgery is performed through left atrium and pacemaker may be needed. Analgesia, opioids, nerve blocks, and regional blocks can be given. Post-operative care. Selected patients can be extubated on table. Endobronchial tube, change into tracheal tube, extubate on table. After changing, can be shifted to ICU and extubate. Criteria for analgesia, normothermia should be maintained, hemodynamic stability is there, no acid-base disturbances, appropriate analgesia can be given to all your patients. Complications, limited availability of data regarding these surgeries. Complications, same as open. People are saying renal, pulmonary, cardiac, pain perception and readmissions, same. Reduced external complications, transfusion, post-operative atrial fibrillation, duration of ventilation, ICU and hospital stay. Conversion to sternotomy in view of bleeding, in view of pleural and pulmonary adhesions, aortic dissections, poor exposure to mitral valve. Assessment of post-operative bleeding. Problems associated with peripheral cannulations, nerve injuries, brachial plexus injury, and Harlequin Syndrome. Complications of one lung ventilation is also there. Acute lung injury, air leak, segmental or lower collapse, pulmonary edema. Minimal access aortic valve replacement should be done with the mini sternotomies or right anterior mini thoracotomies. Central or femoral vascular access for CP bypass cannulation. Advantages are shorter ventilation time, reduced post-operative pain and bleeding, reduced transfusion, less wound infection, shorter ICU stay, and quick return of normal activities, which is required in today's world. Cochrane review, which was done in 2017, and they said there is no difference in mortality, bypass time, aortic clamp time, incidence of major adverse cardiac events. So we have to really think whether we want to proceed on this side or we have to just carry on with the conventional. Anesthesia considerations. Transesophageal echocardiography is must to confirm the position of any intracardiac event. Cardioversion defibrillation be required during surgery. Keep pediatric paddles ready. External defibrillator pads ready. Be ready to conversion to full sternotomy. Minimally invasive pediatric cardiac surgeries. The aim is to reduce the trauma of the operation in the pediatric patients. Better cosmetic results, reduce rehabilitation time and pain compared with traditional open heart surgeries because incisions are big. Minimally invasive incision and CP bypass strategies, video-assisted thoracoscopic surgeries, robotically assisted surgeries, hybrid procedures, and image-guided intracardiac surgeries have been developed in pediatric side too. Improvement of these strategies relies on development of new devices, real-time multimodality imaging, and aids to instrument navigations. Reducing global trauma and mortality requires a multimodal approach, coordinated approach involving congenital cardiac surgeons, perfusionists, anesthesiologists, intensivists, and nurses. The goal is to, beyond technological and medical limitations, to treat more and hurt less. Regional anesthesia for minimally invasive cardiac surgeries as mixed goal are enhanced recovery, multimodal analgesic techniques for post-operative pain control. The regional techniques improve pain control and decreased stay in ICU. So I would like to conclude, minimally invasive cardiac surgeries are gaining popularity in view of their advantages. There is no doubt. Cosmetically accepted, less complications. Understanding the techniques are must and needs training. There are few limitations which we have to keep it in our mind. So this is just the introduction to these kind of the procedures, and my coming speakers are going to speak each and every surgery in detail. These are my references which I have taken for the preparing this talk. Thank you very much for your patience hearing.
Thank you, madam, for a lucid talk on introduction to the minimally anesthesia for the minimally invasive cardiac surgery. With this ongoing COVID-19 pandemic, it is there is a lot of burden on the healthcare system. So fast tracking and implementation of the ERAS protocols are very important. And to do this, we can adopt the techniques like minimally invasive surgeries in various fields. So it is a minimally invasive, but here we require the maximum alertness and vigilance throughout the perioperative period, not only from the assessment of airway, but also to looking at the various investigations, pulmonary function tests, echocardiography, what are these angiography findings are there, whether the CT has been done to HRCT, it's been done so that it is easier for the surgeon to access to the particular the structure which he is aimed to. And even we have to perform Allen's test. Why? Because many of the times there is a requirement of 2 radial artery lines, and so that we will have to perform the Allen's test. All these things we have to take into the consideration before anesthetizing and during operation when the surgeon is busy with his technique. So we have to look after the various, like if the arrhythmias are occurring, if the patient, the heart is fibrillating. So how the defibrillating pads are attached, whether they are properly attached or no. And when they are giving a shock, we have to see that with the pneumothorax, which is created in most of the minimally invasive cardiac surgery, we have to restart the two-lung ventilation so as the current will be passed through the to the heart. So these are some of the points we should have a look into, and also in the post-operative period, uh, because it is through the minimally invasive incision, all these surgeries are going on. So the concealed bleeding can be there inside. So that these patients we have to monitor in the post-operative period in the vigilant manner, and also the multimodal analgesia, which is required for all these kind of surgeries, is very important. And so has to have a safe patient and a fast recovery. So to reduce hospital stay, ICU stay as well as hospital stay. So now we can move to the next topic of monitoring required for minimally invasive cardiac surgery. So to deliver a talk, we have Dr. Super Ho, who is Associate Professor of Cardiothoracic Anesthesia Department, who is also a Deputy Dean of Graduate School, Chiang Mai University, and also Director of International Cooperation of the Society of Cardiothoracic and Vascular Anesthesiologists of Thailand. He is the Executive Board Member of Director of Asian Society of Cardiothoracic and Vascular Anesthesia. He is the Scientific Chairman of ASCA 2022, Chiang Mai, Thailand. I welcome Dr. Suprab Ho to deliver a talk on monitoring for minimally invasive cardiac surgery.
Thank you. Thank you very much for your kind introduction. I will share my slide. Okay. First of all, I'd like to express my sincere appreciation for the fantastic organization of the Device Institute and the AXA Mumbai to organize the academic during the coronavirus pandemic. My talk today will focus on the hemodynamics monitoring in the minimally invasive cardiac surgery, and I will focus in details about how to prevent the preventable pitfalls in this monitoring. And before I go in that, I'm from Chiang Mai University in the north of Thailand, and next year I will host the meeting about the cardiac anesthesia in Chiang Mai, and welcome all of you. And before we go into details about the hemodynamics, we have to understand that the hemodynamics is always changed all the time because its dynamics change going up and down all the time. And for the hemodynamics monitoring for the minimal invasive cardiac surgery, we always have to have the other line to understanding the dynamic physiology. So every time we have the arterial line or the central venous or everything, we have to make sure that our data is reliable or not. How to make sure that the data from the arterial line is reliable? We have to do the square wave test. We flush the heparin flush, and we can see that it's damp or not, under damp or not. And we have to make sure that our data is reliable with zero in the level that is optimum or not. Next step is we have to understand the electrical, mechanical during the cardiac cycle. For example, when the heart ejects, we generate the electrical like ECG going to the pulse. We call the pulse wave transit time. This is the delay time between the ECG going to the pulse oximeter. This pulse wave transit time can generate something. If we understand this, we can multiply to understand another. For example, if the heart ejects and the distance between the ECG to the pulse oximeter is delayed, it relates to the stroke volume is going down. But if stroke volume is going up, the pulse wave transit time will shortening. For example, during ECG, going to the uprising of the aortic root pressure is related to the cardiac contractility. And from the aortic root uprising of aortic root to the uprising of radial arterial pressure, it relates to the blood pressure. And from the radial to the finger pulse, like the pulse oximeter, it relates to the SVR. And if we mix all together, we call it pulse rate transit time. It will relate with the stroke volume. And right now, many equipment can transform from the pulse rate transit time to relate to the stroke volume. Another is during the operation. Some operation we may need to have the leg elevation, or we may need to have the adrenaline during the surgery. For example, one of my studies, the central venous pressure will be related with the position change, and the IVC diameter also change with when we change the position. One of the most important things before we analyze the hemodynamic is we have to understand our goal of anesthesia first, because many people thought that we have to control anesthesia to control hemodynamics. Actually not. We just control anesthesia to be the optimized anesthesia first. If we make sure the anesthesia is perfect, we go to the next step to optimize the hemodynamics. For example, we have to make sure that our patient is not light anesthesia because it's hypertension or tachycardia because of the light anesthesia. We have to make sure anesthesia is perfect. And another, like some kind of shock like hypovolemia or septic shock, the patient will have the tachycardia, hypotension. And that's why we have to make sure, right? For example, the blood pressure is going up. It may be from the vasoconstriction, maybe from the light anesthesia, hypertension, or elderly because of vasoconstriction. But in case of the vasodilatation, it can be from the way, like the general hypotension, shock, or the deep anesthesia as well. And in case that we have the tachycardia, the heart rate is faster. When we have fast heart rate, it may be from the light anesthesia or the hypovolemia or some situation like the low cystic vascular system. And some patients, even though they have the blood loss, but they cannot generate a fast heart rate because they take the beta blocker, or sometimes we have too deep anesthesia. That's why the heart rate or blood pressure cannot be all. For example, when we have a septic shock or something that have the vasodilatation or low SVR, when we have low vascular system, the body tries to compensate to maintain mean arterial pressure by increased cardiac output. And in another situation, not low SVR, but low cardiac output. For example, like during we have the blood loss, during surgery, if we have the blood loss, but the body tries to compensate by maintain normal mean arterial pressure, by maintain stroke volume and the heart rate, right? But sometimes stroke volume or the blood loss make the stroke volume going down, and the heart rate cannot compensate. The body tries to compensate by increased vascular tone and to make the SVR higher. That's why every time we have the blood pressure change, mean arterial pressure change, we have to think about 4 factors combined together. Like this one. If we understand this one, for example, stroke volume. Stroke volume is part of the thing that changes the blood pressure, right? One of my studies is I try to maintain stroke volume higher than another technique. If we try to maintain stroke volume higher, what happens? We can have the cardiac troponin, like the cardiac injury, will be lower in this technique that can make stroke volume higher. And the length of stay in the ICU, length of stay in hospital will be faster, shortening. But how can we have the stroke volume? We can have stroke volume from the traditional approach like swan gas technology, and how to put the swan gas is maybe invasive and take the technique. But my technique, I use the jump and roll technique, like follow the waveform. If the waveform change like this, it will be going to the proper position. However, the cardiac output can come from another technique as well. We can use our TE transfer echo to analyze cardiac output. We can use our arterial pulse contour cardiac output to have the minimal invasive cardiac output as well. Right now, we change to the minimal invasive, like arterial pulse control cardiac output. But if we choose to use arterial pulse control cardiac output, we have to understand the principle of the arterial pulse control, which we have two effects that will interfere of us. First is it will interfere if the waveform change. Second is it will interfere if we have the aortic compliance change. The first thing is, one of my studies, if we change the waveform, for example, we have normal aortic valve. Normal aortic valve, the arterial pressure, arterial pulse control cardiac output is related very well with the swan-ganz. In the aortic stenosis, the data also relate very well as well. But the problem is, when we use it during the aortic regurgitation, the data will be overestimation. Because the aortic regurgitation, the fluid forth and back. That's why it makes the data overestimation before the aortic surgery. And if we have the intra-aortic balloon count, the data also scatter as well. So in case that aortic valve morphology change, like overestimation, aortic regurgitation, we have to think about that. The data may be overestimation. Another is, if we use arterial pulse control, we have to think that this is during vasoconstriction, like a bolus of epinephrine, bolus of norepinephrine or not. If we have bolus of vasoconstrictor, arterial pulse control will going up for a short period of time. And in the same time, one can also going down. This is one of my studies in 2007. And we can apply this one for during surgery, because during minimal invasive surgery, sometimes we not open the midline of the sternotomy. We open just a little, like thoracotomy or some minimal, something that's smaller. But even though it's small, but it still have the painful surgical stimulation, like short stimulation. These short stimulation will increase SVR for a short period of time. The arterial pulse control will increase for a short period of time, about 3 to 5 minutes. The data will be overestimation for 3 to 5 minutes if we use arterial pulse cardiac output. Next step is we will analyze the volume status. When we analyze the volume status in the minimal invasive cardiac surgery, we have to think that some situations we have to understand the difference between the intrathoracic pressure and the extrathoracic pressure, because the venous return is depend on the mean circulatory fluid pressure and the right atrial pressure as well. We have to think about that. Sometimes we use too high intrathoracic pressure or high P or the WAT. We have to think about this as well. And when we use central venous pressure, right now we move to use central venous pressure for another reason, to understand the venous return. But for the fluid responsiveness, we not use the central venous, especially one data to analyze that. If we would like to use CVP, we have to use the before and after fluid training test, because only one data we call static cardiac filling pressure cannot be the fluid responsiveness. Now we use another, like the dynamic one, like stroke volume variation, pulse pressure variation, the flexibility index, because this one is more than one number, it's packed together to show one number, like a variation. And what is this, the dynamic one analyzed from? It's from the heart-lung interaction. When we breathe in and out, during spontaneous breathing, when we breathe, our blood pressure will fall down about 5 to 10 millimeters mercury. This is normal physiologic change. But if the change is increased more than 10 millimeters mercury, it's called the pulsus paradoxus. During spontaneous breathing, the blood pressure fall down more than 10 millimeters mercury. If we understand this, we apply from spontaneous breathing to the mechanical ventilation. During mechanical ventilation, we have the variation as well, but in opposite way, because the shape is not negative, but positive pressure. So we can call it stroke volume variation, pulse pressure variation, or the Respiratory index. When we design to use stroke volume variation, pulse pressure variation, normally the number which is the grade zone is 10 to 15. This is normal. But if we apply intrathoracic pressure or intra-abdominal pressure, like a WAP or increase the P to high P, this number will going up about 3 to 5 millimeters per percent. And then if we decide not to use the minimal invasive like the arterial line, but we decide to use the finger pulse, the finger pulse is totally non-invasive. We can use finger pulse for the PVI, Respiratory index as well. But if we decide to use that, we have to think that this is far away from the heart. That's why the variation is higher, from 10 to 15 to 15 to 20. And if we decide to use the PVI, we have to make sure that the blood flow to the finger is enough or not. We have to have a look at the data of the perfusion index. The perfusion index should be more than 1% in adult and more than 0.7% in pediatric before we analyze the PVI. And we have to use the PVI during not cold, no vasoconstriction, no blood pressure measurements to make sure that the flow to the finger is enough or not. When we make sure that our PVI, PPV, SVV is reliable, we have to get back to the principle of the heart-lung interaction because it will be reliable if we use during control ventilation. Tidal volume more than 8. More than 8 is difficult because right now we do the lung positive strategy. We try to make the tidal volume is 6 to 8. That's why our center, if we would like to do the lung positive strategy, we would like to have the heart-lung interaction for fluid responsiveness. We make the number at 8 to get both. And we have to use it during the closed chest, no cardiac arrhythmia. And how can we use during the cardiac surgery? Because we have an open chest. And the tidal volume may be not enough and cardiac arrhythmia. We will have a trick to use it in this situation. For example, if we have the intravascular volume like this, the first group is the normal intravascular volume. The second group is a compensated intravascular volume. When we generate something like the vasodilatation, like a propofol bolus, we can see that the first group, the blood pressure is not changed, but the second group, blood pressure is changed. Because of what? Because in the beginning, the first group SVV is 8. The second group SVV is 18. 18 is like in the borderline, but after vasodilatation, it cannot compensate anymore. SVV is going to 28. This is the trick to use. And another is, if we would like to prevent hypotension after induction, how can we do that? We can have many choices. The first choice, we just maintain the SVR, like giving some vasoconstrictor, sympathetic stimulation, or we can adjust the choice of anesthetic drug to use another, for example, mixed with ketamine or something. And the second choice, we just give the fluid resuscitation or just titrate the propofol or another medication like the light anesthesia. But if we decide to use the fluid resuscitation, we have to think that our fluid resuscitation is going to the plasma state like this, like a glass of blood like this. When the glass of blood have the vasodilatation, the same blood volume is the same, but the glass is bigger. When it's bigger, the SVV going to from fluid non-responsiveness, it moved to be fluid responsiveness. From this non-responsiveness moved to be responsiveness because the volume is the same, but the glass is bigger. In this situation, how can we solve this problem? We just give fluid, right? Yes, because it's fluid responsiveness. But actually, we may not need to give fluid all the time. We may give certainly vasoconstrictor because we know the principle of this situation. And every time we have a number like this is a low number, fluid non-responsiveness. I have to ask myself all the time, is the tidal volume more than 8 or at least 8 milliliters per kilogram or not? Is it during controlled ventilation or not? Or is it during closed chest or not? Because if the number is low during open chest, we cannot interpret that. But if the number is high during the open chest, it's called fluid responsiveness for sure. And in case that we have the high number, like fluid responsiveness, can we rely on that before we give the fluid? I have to get back at is it the physiologic PEEP or not? Because too high PEEP will increase this number to going up. Or if we have the cardiac arrhythmia, the surgeon move the heart, we will have another variation. The number is going up. So before we analyze this number, we have to think about this. Because we analyze this number, we have to think about this. But in case that we're not sure that the data is reliable or not, we just give the leg elevation, because sometimes we don't have to give fluid and get the result, the diuretic after that. In case we use a propofol or the sevoflurane, or no matter we use the desperate, the frank saline mechanism still preserved during the perioperative. And in case that we use the closed chest or some open chest, we're not sure that our variability or the TPV, SPV is reliable or not, we just do the fluid challenge test. Fluid challenge test is we give the small amount of the fluid and we follow the number of stroke volume. If the stroke volume increase more than 10%, it's called fluid responsiveness. We can give more and more fluid. For example, this one is clean. The clean one is fluid responsiveness. The red one is fluid non-responsiveness. If in the beginning our stroke volume is 30, we not know where we are because certainly one number cannot interpret. We just give fluid. If fluid from 30 move to 48, from to 40 it increase more than 10%. If it increase more than 10%, we give fluid more. This is more than 10. From 72 to 80 is about 10%. So we starting to almost stop. But 80 to 84 is less than 10. We should stop fluid loading. This is the trick to use during the open chest. And plus, if we have the stroke volume variation, it can show like this. The tip and trick to use the SV together with SVV is we can titration of the fluid to have the optimum volume. When we have the optimum volume and we have a look at the SV, if the SV is 80, we have good heart. 60 is heart is okay, but less than 40 heart, we have poor heart. For example, in the beginning, we have stroke volume is very low. SVV is fluid responsiveness. We just give fluid. When we give fluid, it's going to the fluid optimization. But we know that we have the poor heart because it's very low graph, right? What we have to do after this, because it's too low, we have to give inotropic support in this situation. Next step is tips and tricks to use with the PEEP. With the PEEP is, because PEEP is very popular right now for the lung quality strategy. One of my studies is when I apply PEEP, more than 0, more than 5 to 10. 10 is more than physiologic PEEP. The number will also interfere the number of the cardiac output, the number of the central venous pressure as well. But the volume is the same. The PEEP from 0 to 5, what happened? In this situation, nothing changed because the PVI is fluid non-responsiveness. In this situation, fluid non-responsiveness, we no need fluid, no need more fluid. From 5 to 10, what happened? It moved a little bit down, but blood pressure is not down because fluid is okay. But in another situation, if in the beginning we have the borderline, in the borderline from 0 to 5 is okay, but from 5 to 10, something happened. It can show that the fluid is responsiveness, we need fluid. If we not give fluid, the process fall down. So another tip and trick, if we don't have the sophisticated monitor, we just apply the PEEP. If we apply the PEEP and the process fall down, it's another trick that we need fluid in that situation. Our fluid status is not so good in that situation. The last step is the microcirculation. After we analyze the macrocirculation, we make sure that the macrocirculation is perfect. Next step is we go to the microcirculation to make sure that our hemoglobin, our oxygen is going to the organ very well. Our specific organ is like in the brain. How to make sure that? We just optimize the macrocirculation. Like step 1, we optimize the fluid responsiveness. We optimize the contractility. Some person would like to do step 2 first, step 1 second. It's okay, up to you. But in my practice, I do both fluid and the contractility in the same time. After we optimize the macrocirculation, we go into the next step about the microcirculation. The microcirculation is depend on how sophisticated monitor that we have. For example, if we don't have anything, we have simply central venous catheter. We just draw the blood sample to send the arterial blood gas. If it's less than 70, it's called the microcirculation. It's not so good. Or if we have lactate in arterial blood gas, if it increases more than 2, it's related with the poor microcirculation. Or if we have the NIA, the cerebral oximeter, we can attach to the left side and the right side. Normally, it should be more than 50%. Or if we have the high number of the baseline, if it's lower than 20%, it's not so good. But if we're not sure that our beginning, the number is how much, we don't know because the patient come to emergency surgery, we don't know if it's a good baseline or not. We just maintain it to be more than 50 all the time. If it's lower than 50, it's called we have some problem with the microcirculation. What we should do when we have the problem of the microcirculation, we can solve the problem with the 4 solutions. The first solution is optimize the contractility. We can optimize contractility by maintaining flow volume, inotropic support, or heart rate. And we optimize the hemoglobin because hemoglobin is part of the oxygen content. And we optimize with the oxygenation. And next step is to reduce oxygen consumption. One of the most important things is during the surgery is the hemoglobin carrying. One of my study is when we have the hemoglobin low. My study is like acute normolomic hemodilution. We give the blood out, take the fluid back to maintain normal volume. And in case that we have fast heart rate and slow heart rate, what happens? The SVR is changed after we have the hemodilution, and the oxygen consumption and oxygen delivery also change. To summary of this is when we have very low contractility, we can maintain hemoglobin high. Or like this one, the green one is we have very good contractility. Very good contractility, we can maintain hemoglobin low. But if we have very poor contractility, we have to maintain hemoglobin high. This is just only two things connection, but actually we have 4 things connection. For example, in the beginning, we calculate oxygen delivery is very low, like only 160. Normally it should be more than 400, 450. In the beginning, it's low hemoglobin, low oxygenation, low contractility. What we should do? We just improve the oxygen saturation. It increases a little bit, but after I improve the contractility from 2 to 3, it improved to this. And next step is I improve the PO2. It just only this. But last step is if we improve the hemoglobin, it's going to reach the point. So hemodynamic optimization is not only give inotropic, hemoglobin is part of that, and everything is mixed together. For example, if we have the situation is not so good, like like when we have hemoglobin, increase in affinity of oxygen, like my wife. She grabs and hold money tightly like this. It's moved to the left. Hemoglobin dissociative curve moves to the left. Or for me, when I have like a sugar daddy, will get easily pay money or oxygen out when hot and worse and or acidosis. The payment will be easier if they have the sexy 2TD pretty ticker like this. So it depends on the situation. If we have a difficult situation like this, we have to maintain oxygen high. This is summary of my talk is many technology right now change from the invasive to the minimal invasive one, and many technology adapt itself to our culture, adapt itself to our technique of surgeon. That's why we have to understand that it's sensitive, it's gentle, and we have to adapt ourselves to understand how to use it properly and maximize the effectiveness of the minimal invasive monitor or the minimal invasive cardiac surgery. And the benefit is not for us, but the benefit is to our patient and our population. And thank you for your attention. ขอบคุณครับ สวัสดีครับ And would like to welcome all of you to Chiang Mai next year in the end of next year after the pandemic. And I hope that COVID-19 pandemic in India will recover very soon and all safe. Thank you very much.
Thank you, Dr. Supako. It was an excellent and exhaustive lecture on hemodynamic monitoring during minimally invasive cardiac surgery. The other monitors like TE monitor is also useful as a hemodynamic monitor, and also it helps us to take to use as a decision making tool. Whether proceeding for whether the minimally invasive cardiac surgery is possible or not, because sometimes there is the presence of left SVC which is not detected during transthoracic echocardiography, or the transesophageal echocardiography is also helpful during cannulation of the peripheral cannulation through the femoral vein of SVC and IVC when the two-stage cannulation is being performed for the position of the proper cannula. Then positioning of the end-aortic balloon placement, that is also helpful for the cardiac patient. So the T is also hemodynamic as well as the diagnostic tool here in minimally invasive cardiac surgery. When the chest is closed, we cannot see the heart. The sternotomy. So I think T is also a helpful monitor. Again, apart from these hemodynamic monitors, the other monitors like cerebral oximetry monitor is also helpful. When this Harlequin Syndrome, which is the most known complication of this minimally invasive cardiac surgery, where the more oxygenated blood is coming to the abdominal aorta, while the less oxygenated blood is coming from the upper body, especially when the patient is not getting ventilated on CP bypass. So that time, if this occurs, then the severe cerebral hypoxemia can occur, and that can be detected with the infrared spectroscopy, cerebral oximetry we can detect. And that of anesthesia monitoring is also very important in such minimally invasive cases, because we want a fast tracking of this patient. So if we tailor our anesthesia management with this help of either base or entropy monitors, and it will be helpful for us in the fast tracking of this thing. So otherwise, it was an excellent talk. I am fascinated with your various graphics, which made us to understand the hemodynamics very easier, and also it is very useful, especially for the postgraduate students who will understand how the various hemodynamics, how they alter with the help when we are giving PEEP, even we are not giving PEEP, how how to tailor the management of hemodynamics, like if there is a hypotension, whether to give a fluid, which fluid should be given, or a vasoconstrictor should be given, or whether we need to add something else. So it was a very excellent and exhaustive talk. Thank you for such thing and delivering the talk for today's session. Now I hand over this mic to Dr. Prasanna for the further proceedings.
Thank you. Thank you, Dr. Suprafong, for that wonderful lecture. Thank you so much. I think everybody has appreciated it. And thank you, Dr. Manjula Sarkar. And I would also like to thank Dr. Sanjita Umbarkar to moderate this session, who has moderated it. Thank you, all of you. So we now start with the second session, where we will look at the anesthesia considerations in these cases, like for coronary artery bypass surgery, then for aortic valve surgeries, and then for mitral and tricuspid valve surgeries. So to moderate this session, we have Dr. Vishwas Sathe and Dr. Selva Kumar. So Dr. Vishwas Sathe is a professor in anesthesiology, the cardiac unit at the Department of Anesthesiology, MGM Medical College and Hospital, and MGM Institute, that is a Maharashtra MGM, that is a Mahatma Gandhi Mission Institute of Health Sciences. This is at Navi Mumbai. He is in charge of the MGM Skills Lab. He is the American Heart Association Regional Faculty of India. He is a ATLS instructor and also the CALS instructor. And he has 6 international publications. To moderate along with him, we have Dr. Selva Kumar. So Dr. Selva Kumar finished his MBBS in 1991, followed by MD Anesthesia from KMC Mangalore in 1997. And then he developed his interest in cardiac and neuro anesthesia. He completed his PDCC from Apollo Hospitals, Chennai. And then he has done his, then he was a junior consultant and a chief anesthesiologist at Apollo Hospitals, Chennai and at Madurai. And then now he's currently the director of medical services at Vedamal Hospitals, Madurai. So he has over 21 years of experience in cardiac anesthesia, done more than 10,000 cardiac surgeries, 2,000 neurosurgical cases, 150 renal transplants, and 15 liver transplants. And he's one of the senior most cardiac anesthetists and intensivists with 21 years of experience in South Tamil Nadu. So welcome both of you. So I now hand over to Dr. Selva Kumar.
Good afternoon, everyone. It's very pleasant afternoon. And I should thank the organizers for giving us this opportunity for both listening this lecture and as well as also to chair a session. First 2 lectures were very informative and very interesting. We should thank both the speakers. So now we'll move on to the session 2. The session 2 is to the pertaining surgery. For example, directly about the CABG, followed by mitral and followed by aortic valve. So in each surgery, how we are going to manage, what are the anesthetic considerations for that particular surgery. So with this session 2, we have 3 speakers. First speaker is Dr. Pushkar. So he's going to talk about anesthesia management for CABG. Anesthesia management for CABG is a routine process for a wide number of years. But here the interesting point is minimally invasive CABG. That is the clinching point. So we welcome Dr. Pushkar. Basically, he has completed MD and DM cardiac anesthesia. He's a senior specialist in Sultan Obas University, Muscat. And previously was a former assistant professor at KEM Bombay. It's well-renowned hospital. And for his credit, he has got more than 15 national and international publications. I request Dr. Pushkar to talk about anesthesia management for CABG in minimally invasive cases. Over to Dr. Pushkar. Please take over.
You have to unmute yourself, Pushkar. You have to unmute yourself. Yeah.
Am I audible now?
Yes. Thank you.
Thank you, Dr. Selva, sir. I would like to thank ACTA Mumbai and Dr. Manjula Sarkar for inviting me in this webinar. And I pray for everybody's health in these tough times. So basically, the topic given to me is anesthesia considerations for minimally invasive cardiac coronary artery bypass surgery, or CABGs. So I would like to talk about the classification of minimally invasive cardiac surgery first. So the minimally invasive cardiac surgery, they are classified into epicardial and endocardial surgeries. So epicardial is, you can say, it's above, the chambers are not open. So it involves the mid-cap, that is minimally invasive direct coronary artery bypass surgery, which can be done in 3 ways. So it is either beating heart surgery, or it could be the pump assisted beating heart, or pump assisted with cardioplegia, or it could be totally endoscopic, that is a robotic cardiac surgery, CABG. The other types of surgeries are endocardial surgeries, including valvular surgeries, intracardiac repair of the congenital lesions like ASD, and then cardiac mass resections like myxoma. So basically, I would like to talk about the mid-cap surgeries, and I will talk about the definition, classification, what are the merits and demerits of mid-cap. Although the anesthetic considerations for the CABG surgery is standard ones, so I would not emphasize much more on that aspect. Rather, I would like to highlight the important which is relevant to the anesthesia in a minimally invasive CABG. So coming on to the classification of MICS, Carpentier and Wilmette classification, they have classified MICS into 4 levels, which depends upon the size of the incision and whether it is under direct vision or the totally endoscopic, like robotic vision. So as the size of the lesion incision reduced from around 10 to 12 centimeter to less than 1.2 centimeter, that is just a port access surgery. It can be classified from level 1 to level 4. So what are the advantages of this MICS CABG? So as the name suggests, the main difference between the conventional CABG and the minimally invasive CABG is avoidance of the full sternotomy in mid-cap. So which results in the rapid wound healing, less pain to the patient, less blood loss, and less transfusion to the patient. So eventually culminating into the lesser post-operative infection, fewer restrictions of the physical activity, reduced hospital stay, and early recovery. But simultaneously, there are some disadvantages or demerits of mid-cap. Like the main disadvantage is the steep learning curve for the surgeon, right? The second one is not all patients are amenable or suitable for the mid-cap. There are definitely a limited patient population, limited number of patients who are suitable for MICS. Of course, we don't consider the additional cost required for MICS, considering the setup of OT and the costly instruments. Regarding the complications, the literature has suggested that there is definitely high incidence of stroke in minimally invasive cardiac surgery. This is definitely related to the peripheral cannulation and coexistence of the peripheral vascular disease. So there might be atheroembolism might be occurring. So definitely there is a higher incidence of stroke. Apart from that, since it is a limited space surgery, there is as compared to the conventional surgery, the phrenic nerve palsy injury, that the chances are very high in MICS. So this is a schematic diagram basically showing how to access during the mid-cap. So the incision is usually in the left 5th intercostal space. It is an anterolateral incision. After the incision, you can see the cardiac apex, the left internal thoracic artery, LAD, and all the branches of the coronary arteries. They are seen in this thing in MICS. Then for the anastomosis purpose, we use this apical stabilizer, that is starfish, and the epicardial stabilizers, octopus. So basically the picture looks like this. there are certain differences between Medicab and the MICS CABGs, and they are mainly related to the surgery. So the first and foremost important difference is MICS CABG as compared to the Medicab is usually a complete revascularization procedure, whereas in Medicab the standard definition is just Lima to LAD anastomosis. Secondly, the MICS in CABG, the thoracotomy is more lateral and often it is a small in size. The rib spreading is less, so eventual cost to control injury is less in MICS. MICS can be performed even if the lung is deflated. The surgeon usually pack the posterior aspect of the lung where it goes and they can proceed. Then the whole length of the lima can be harvested in MICS CABG as compared to the Medicab. Okay, so we can the surgeon can skeletonize the lima right from the origin, from the subclavian artery. So the chances of the steel phenomenon, they are less in the MICS. Then all coronary arteries and all the territories are amenable for grafting in MICS. And ascending aortic, this proximal anastomosis, they are easily amenable in MICS, although there are some surgical techniques which I'll be describing later on. Okay, now coming on to the pre-op evaluation of those patients. The pre-op evaluation, they are usually similar to the conventional cardiac surgery. The pre-operative standard history, the physical examination, investigations, and imaging, they are all same in MICS. Okay. Apart from that, the important points to look, they are in cardiovascular examination. Usually the presence of PFO, persistent left SVC, any coexisting valvular pathology, they are sought after because all these comorbidities or the lesions, they make the MICS difficult and the surgical plan has to be changed. Then as the vascular system assessment is done using CT angiography, because this peripheral vascular cannulation is often performed during MICS. So even if the sternotomy is avoided, the groin and everything is groin area is prepared for the peripheral cannulation. So in case the surgeon decides to proceed with the peripheral bypass or femoral bypass, the anatomy of the femoral vessels, they should be thoroughly evaluated using CT angiography in the preoperative period. Although the presence of plaque, aneurysm, they are usually seen in CT angiography because these are the risk factor for the post-operative stroke. Then coming on to the respiratory evaluation, which is for us, we usually look for whether the patient is suitable to tolerate the one lung ventilation in MICS. So we assess the respiratory system using pulmonary function test, and FEV1, which is less than 40% in the preoperative period, baseline ABG of the patient showing PO2 less than 60, PCO2 more than 50 millimeter of hemoglobin mercury. They are usually standard parameters which suggest the poor perioperative outcome of the patient, and that these patients are not suitable for one lung ventilation. The extra investigations would be DLCO, that is a diffusion lung capacity of the carbon monoxide, which is 40%. It should be which is less than 40%, suggests that patient is having poor pulmonary function. Also, the presence of pulmonary artery hypertension is to be ruled out. Although because the pulmonary artery hypertension already in presence of one lung ventilation, the life becomes much difficult. Okay, because it increases the RV afterload. Coming on to the other systemic evaluation, as the T is the integral part of the surgery, we should always look for the GI evaluation. the presence of any esophageal stricture, tumor, laceration, upper oropharyngeal injury, active diverticulum, upper GI bleed, they are all contraindications for the D. So we should always look for those factors. Coming on to musculoskeletal system, because these patients are positioned in the supine with some right lateral tilt with their hemithorax elevated, and usually the arms are tucked tightly by the side of the patient, so it usually develops some traction over the brachial plexus. So these patients in the preoperative period, they should be evaluated for any musculoskeletal deformities. Coming on to chest wall deformities and any prior history of radiation, trauma, any history of ICD insertion, these are all relative contraindications for the MICS, because the surgical access is difficult in those conditions. Extreme obesity, that is morbidly obese patients, they also possess relative contraindications for MICS, as well as a small body habitus, and that is the diameter of their intrathoracic cavity capacity is less in those patients. So the space available for the surgeon is less. So these are all relative contraindications for the surgery. Coming on to investigations, apart from the standard investigations, the extra investigations what we look in preoperative period is pulmonary functions test, echocardiography, CT angiography, coronary artery angiography, and carotid angio. In echocardiography, usually we look for any associated lesions, that is in PFO, which I have described. Apart from that, the anatomy of the heart, or any hypertrophy of the LVH is present, because the bigger heart, they are difficult to operate in the small space. So these things should be looked in the echo, apart from the biventricular function. Then in CT angiography, it's mainly to assess the peripheral vasculature. Coronary angiography in the preoperative period, it's a good habit to assess coronary angiography, because we can have the idea of size of the coronaries as compared to the catheter. Anything which is less than 2 millimeter, we can be assured that there will be some difficulty after the anastomosis. So we should be prepared for the plan. Now, carotid angiography is usually done to rule out any carotid atheromatous plaques, and in the perioperative period. Coming on to the optimization, during pulmonary optimization in the day before surgery, usually if the patient is smoker, we usually ask them to quit smoking. If patient is a COPD and taking some medicines, usually we continue the bronchodilators and steroids till the morning of the surgery. Interpretively, when the patient comes inside theater, the important thing is placement of the defibrillator pads. We should place it in the correct location. The left pad should be placed relatively higher in the left scapula, and the right pad should be placed below the nipple and somewhat angled anteriorly, medial to the nipple line. We should take care that the nipple area is avoided. This position usually will be just outside the build, because the chest is kept open in case of any eventuality into conversion to open sternotomy. So basically for putting the defibrillator pads, the vector of transmission of the current should be kept in mind, and more of the lateral passage of the current is to be sought. Then ECG leads placement, because of single lung ventilation and the presence of pneumothorax in the left-sided thoracic cavity, the vector of the ECG monitoring is disturbed in these cases. So these leads should be adjusted so that the particularly V4 to V6 leads, they should be adjusted, and the extra monitoring should be taken, should be considered, just to rule out during intraoperative period to supplement the onset of ischemic changes. Coming on to induction, there is a standard induction. We should maintain the normal cardiac output and maintain the cardiac rate. During induction, any tachycardia is to be avoided. Simultaneously, sudden drop in the SVR should be avoided, as maintaining the normal contractility and the normal sinus rhythm. So this is fair enough. So accordingly, as per the institutional practice, the standardized induction using propofol or etomidate or opioid should be carried out. After the induction, the position of the patient looks like this, where the left arm is tightly tucked by the side of the patient, and there is some sandbag is placed below the right shoulder, so that the hemothorax is elevated for the surgical facilitation. The surgical view is enhanced due to this, but the drawback is that because of the traction on the ipsilateral arm, the patient might develop the brachial plexus neuropathy in the post-operative period. So accordingly, all the pressure points to be added during the position. Particularly, we should take care of the ulnar nerve padding. Coming on to the monitoring, the standard ASA monitoring is advised. Apart from those, invasive monitoring like arterial waveform and the central venous calibration, they are performed as usual. Cerebral oximetry is important in minimally invasive surgeries. If the surgeon is planning to use the peripheral bypass or the cannulation, if it is not a beating heart surgery. Pulmonary artery catheter is to be used as per the institutional protocol. PAC is usually useful. It offers some advantages. Of course, the TOE has taken over the role of PAC in recent times, but still the PAC offers us to evaluate the mixed venous saturation in the perioperative and the post-operative period. Also, the utility of the PAC lies in the post-operative fluid management, where the fluid management can be carried out using the wedge pressure or the pulmonary artery diastolic pressure. So this is one of the advantage of the PACs, pulmonary artery catheter. Regarding TOE, this is a 2020 article from the JES, which is they have published it as guidelines for the TOE during cardiac surgery, and they have comprehensively described all the indications of TOE during all types of surgeries. So I have taken this part during the CABGs, where the TOE monitoring is revolved around assessment of the biventricular function, including the LV anatomy, then any regional wall motion abnormalities during the pre-grafting and the post-grafting period, assessing simultaneous assessment of diastolic function. Apart from that, CADS grading should be performed in TOE. We should always look for any evidence of atheromatous plaque in the aorta. Particularly if grade 3, grade 4 plaques, they are a contraindication for the endovascular balloon placement in the MICS, even for the side biting clamps also. So if the surgeon, this is the role of TOE during cannulation. So basically, this is a venous outflow cannula. So we should always look for the position of the guide wire in midesophageal bicavity. And once the guide wire is negotiated across the IVC into the RA and into the SVC, the cannula is threaded over the guide wire, and the final position is to be checked in the same view. Regarding the arterial inflow, this is a should be imaged in the descending thoracic aortic short axis view, where we should always look for the position of the guide wire. The guide wire after after the position is confirmed, the cannula is to be threaded over. If the endovascular balloon is to be planned during the other surgeries, particularly the valvular surgeries, or if the surgeon is planning to do it beating heart CABGs, then the position of the endoaortic balloon should be confirmed using TOE. It should lie upon around 2 centimeter above the coronary, above the origin of the coronary ostia, and the diameter of the ascending it should be less than 3. Anything more than 4.5 is a relative it's a contraindication for the placement of endoaortic balloon, because it will not seal the aorta, and the cardioplegia solution won't be delivered properly into the coronary ostia. So during the cardioplegia delivery, we should always look for the color flow Doppler across the ascending aortic view. There should not be any blood flow between the wall of the aorta and the wall of the balloon. Then we should always look for the any evidence of LV dysfunction. So if the cardioplegia is going on, and if we see that LV is distending, that means that patient is having a severe or a significant aortic regurgitation, and it will impair the myocardial preservation in the preoperative in the intraoperative period. So, coming on to the lung isolation. So as per the institutional protocol, we should either the double lumen tube is used or the bronchial blocker is used. So there are advantages and disadvantages of each thing. Although the double lumen tube is a relative contraindication, or it's difficult to place in patients having a difficult airway. So in those cases, bronchial blocker placement is to be sought after. Apart from that, DLT is relatively easy to suction the airways because of its large lumen, and absolute lung separation is guaranteed using DLT. As far as bronchial blockers is concerned, they are usually relatively quick, and they can be passed through single lumen tube, so they can be used in difficult airway situation. So there is a during intubation, there is as the size is small, there is airway injury is avoided using bronchial blockers. But at the same time, we should have one should have the expertise in putting the bronchial blockers. The commercial options available, I mean, which are relatively easy, they are either easy blocker or uni blocker. So uniblocker is placed through the single lumen tube, and in expert hands, within a few minutes, we should be able to isolate the lungs. As far as the easy blocker is concerned, the 7 French easy blocker is very easy to put, and of course, the after placement, we should be able to do the fiber optic bronchoscopy to confirm the position of the easy blocker. So the important thing to note here is that if you are using easy blocker, the endotracheal tube should be placed well above the bifurcation of the carina, usually 4 centimeter, because the distance of distal tip or the distal balloon in easy blocker is around 4 centimeter when it comes out of the single lumen tube. So if you are using the uniblocker, you should lubricate the uniblocker so that it should go smoothly. Just avoid the lubrication over the balloon part, because it might dislodge during the placement. Okay. Then position of the tip of the blocker should be around 2 centimeter below the carina. And after positioning, we should always confirm it with the fiber optic bronchoscopy. These are the standard guidelines for choosing size of the DLT and the blockers. usually the male patients, they take 39 to 41 French double lumen tube. As per the height of the patient, any less than 170 centimeters usually go for 39 French DLT, whereas in females we usually prefer 35 French to 37 French DLT. As far as uniblocker is concerned, there are two sizes available, 5 French and 9 French, and easy blocker is most commonly used size is 7 French. Coming on to the management during one lung ventilation, if the patient is unable to maintain the saturation during one lung ventilation, there is a protocol that is stepwise we should tackle the problem. First, initially we can give the CPAP to the non-ventilated lung, and which can be given using a modified, you can just attach the syringe to the bronchial lumen or the DLT this thing, and DLT connector, and you can insufflate the oxygen around 6 liters per minute. So it can act as a wonderful CPAP method for non-ventilated. If it does not resolve the problem, we should try to play with the physiology of hypoxic pulmonary vasoconstrictions. Any vasodilators, ongoing vasodilators should be stopped, including inhalational anesthetics, and the plane of anesthesia is to be maintained with IV anesthetic. So in that period, the cerebral oximetry is useful to guide the plane of anesthesia also. If it is not been corrected, then we can give the PEEP to the
recording stopped. Recording stopped. Recording in progress.
Yeah. If then we should apply a PEEP to the dependent lung, ventilated lung. Then initially the PEEP is applied to the around 5 centimeter of water. The disadvantage of,
sorry Pushkar, you just time up, and you means in some time you can, because you just another couple.
No, because am I audible? I am hearing some sound.
No. I'm just saying now. Maybe just a couple of minutes, because we are just.
Yes.
Thank you.
Yeah. So if the problem of hypoxia is persisting, we should always communicate with the surgeon, and two lung ventilation is to be reinstituted. If still the problem is persistent, we should always look for the reversal of shunt in case there is a PFO is present. So in that case, the TOE monitoring is helpful. Considering the steps of the surgery, there are standard steps in this mid-cap. Initially the surgeon harvests lima, then followed by the proximal pericardial opening, then ascending aortic mobilization, followed by proximal anastomosis, then distal pericardium is open and the targets are checked, and then the distal anastomosis is performed. During proximal anastomosis, we can give the PEEP to the right lung in around 10 centimeter of water, so it can shift the mediastinal structure to the left side, and we can help the surgeon in the easy visualization of the structures. During this proximal anastomosis, also the standard we have to maintain systolic blood pressure between 90 to 100, and that can be achieved by using a deeper plane of anesthesia. We can give the reverse Trendelenburg position to the patient using minimal vasodilators like nitroglycerin, then adjust the vasopressor infusion. We should stop it if required. Hemodynamic alterations, they are usually taken place during the distal anastomosis. Usually the lima to LAD anastomosis is not producing any hemodynamic alterations. But for PDA and the marginal branches of circumflex artery, the hemodynamic perturbations are significant. So for that, the surgeon usually places the starfish or the epicardial stabilizer, so that to elevate the heart, and the apex is pushed toward the left shoulder in case of visualization of the right-sided coronary artery branches, RCA branches, and that might produce the twisting of heart and reduce the preload. So the hypotensions is produced during that period. regarding the circumflex artery, the OM1 and OM2 grafting. OM1 is relatively easy as compared to OM2. The more lateral the branch, greater is the twisting of the heart, and lesser will be the preload. So the hypotension ensues during that period. Coming on to the ischemic spiral coronary artery bypass surgery. Initially, the hypotension sets in, which results into the reduced cardiac output, which translates into the increased circulation time. So whatever drugs we give, they are not reaching to the targets, and the effect is not being produced. So the reduced drug effect, so more drugs, we tend to give more drugs, and ultimately what happens is either the patient lands up into the extremes of pressures, or patient, due to persistent hypotension, the heart fibrillates. So basically this ischemic spiral we should avoid, and for that the important thing is just to maintain the good BP prior to manipulation of the heart, so which can be achieved using table maneuvers and the judicious use of vasopressors. Apart from that, the surgical alternatives to reduce the blood pressure, to maintain pressure, is meticulous placement of the intracoronary shunts, careful positioning of the heart, of course, quick anastomosis, and if nothing happens, IBP, we can place the IBP or convert it into the open heart surgery in case of emergency situation. In case of this MICS, usually the epicardial stabilizer and the octopus, they are placed on the opposite side of the table. So if after the engagement of both stabilizers, we should not move the table. So this is a very important point. So if you want to maneuver the table, you place after the placement of starfish or octopus first, then the heart is positioned, and then we should maneuver the table. And once the optimal hemodynamics achieved and we are satisfied, then we can ask the surgeon to place either the other stabilizer. Either it could be octopus or starfish.
Dr. Pushkar, sorry, but you'll have to, can you conclude in some time, because we have,
yes,
because we have crossed the limits. Yeah. Thank you.
Preload, coming on to the hemodynamic management during hypertension. As I said, that adequate preload has to be maintained using good, we can give Trendelenburg position to the patient, alpha agonists like phenylephrine we can use judicious vasopressors like noradrenaline infusion, and of course if nothing happens, we can reposition the heart and give some time to the heart to stabilize. Coming on to the complications, the arrhythmogenic complications are important during CABGs, and they should be tackled accordingly. And most of the complications, they are related to the positioning, and the careful positioning during the by the surgeon, usually it avoids the arrhythmia. Coming on to the sick heart, basically which is dilated and the poor contractile heart, which is bigger in size, so it possesses the surgical challenge to the surgeon in the small thoracic cavity. So our aim is to increase the heart rate and reduce the size of the heart. How can we do it? We can just pace the heart either using pacing wire, or we can give some beta agonist. Then we can use inodilators, which will reduce the PA pressures and increase the contractility. Effective use of IBP also helps during these situations. Post-anastomotic LV dysfunctions, which is usually happening after the grafting, and the causes could be the air entrapment into the coronaries, or due to small sizes of the vessels, and grafting quality of the grafting might not be adequate. So these things we can anticipate by looking into the pre-operative coronary angiogram. And the management should be aimed towards increasing the systemic blood pressure and reducing the PA pressures. If the patient is having the mitral regurgitation, we should continuously monitor the amount of MR during heart position using TOE, and the standard cardiac rate is to be maintained by reducing the afterload and increasing the heart rate. Then practical problems during Medicab are loss of lung isolation during the procedure, which is how we can diagnose it by raised peak inspiratory pressure, and the EtCO2 is amplitude is reduced because the balloon is migrated into the carina. Then if sometimes we are unable to defibrillate the patient using external defibrillator, so the pediatric defibrillator pads should be kept handy. Or if nothing happens, the emergency conversion to the open sternotomy should be instituted. SVC injury might happen during the mobilization of the ascending aorta. So in the during that time, the TOE monitoring in the ascending aortic short axis view, it usually reveals the any SVC compression or the injury. Then right pneumothorax, it's usually revealed at the end of surgery, which might happen during the lima harvesting, and the epicardial maceration might occurs, and post-operatively it results into the cardiac tamponade. And due to the small cavity, sometimes the retained foreign body like sponges are sometimes it happens. So we should be vigilant during that period. So after the surgery is over, the adequate suction is done. Suction of the lung is done. Then check bronchoscopy is done prior to inflating the left lung, and the slow manual inflation of the left lung is carried out. We should always lung is inflated under the vision, so that there should not be any traction on the lima and the grafts. Then we should rule out, the surgeon should rule out the king graft due to the lung expansion. Then it's always a good idea to do the check echocardiography at the end of procedure, and we should monitor the drain output before before shipping the patient out of the theater. Coming on to the pain management, the standard pain management in MICS, opioids and use of regional anesthesia, and the non-opioid drugs like dexmedetomidine, pregabalin, they are they are used and usually helpful. The one important thing is what in our experience we use the on-cue catheter, which is at the end of the surgery, the surgeon places inside the incision, and the continuous local anesthetic infiltration is carried out in the post-operative period, and it usually gives excellent pain relief in the post-operative period. So coming on to regional.
Excuse me, Dr. Pushkar.
This is the last slide, sir.
Okay.
Yeah.
Make it fast.
Coming on to the regional anesthesia, we have different alternatives like thoracic epidural, paravertebral, serratus anterior block, neurofacial plane blocks. Among all those, erector spiny blocks, as per the literature, gives the superior pain relief, followed by the intrapleural analgesia, which the surgeon places the catheter in between the visceral and the parietal pleura. So in a nutshell, even though the surgery is minimally invasive, we should have the maximum awareness along with the maximum vigilance, and we should always continuously coordinate with the surgeon and the perfusionist, and communication should be there during the surgery. Thank you.
Thank you, Pushkar. It was a good lecture. Only thing is that you couldn't keep up your timings, but you have a lot of slides to talk about. And you
I lost my slides. Anyways, it's okay. I lost my slides and my presentation in between, so that's why I was fumbling. I'm sorry about that.
This type of webinars, we expect some kind of technical problems. We all should agree about that. Anyway, thanks a lot for your good contribution. And one word about this technique is, this is the only future technique to keep all the cardiac surgeon and cardiac anesthetist to convince the patients over PTCA in near coming years. So this is a very good topic, and I think I'm you're done. Thank you. Thanks a lot. We over to the next topic. Next chairperson will enter. Yeah.
Yeah, Vishwas.
Yeah. Yeah, am I audible?
Yeah, Vishwas.
Yeah. First of all, thank you, the organizers, for giving this opportunity. And now to introduce the next lecture, it's by Dr. Dheeraj Arora. Dr. Dheeraj is a principal consultant at the Medanta Institute, which is in Delhi National Capital Region. He has around 50 plus publications to his credit, and he has presented over 80 presentations, both national and internationally. He is also the executive member of the Indian College of Cardiac Anesthesia, as well as he's also on the editorial board of the Annals of Cardiac Anesthesia. So over to you, Dr. Dheeraj Arora. We're looking forward to hearing your experience in anesthesia for mitral and tricuspid valve surgeries.
Thank you for the nice introduction, chairpersons, and I want to thank ECTA Mumbai and Dr. Manjula for inviting me. I want to thank my previous speaker also because he has made my job easy. He has covered most of the topic. This is my institute. Now, this is the general outline of my talk. It will be introduction followed by review of literature, then anesthesia consideration covering the pre, intra, and the post-operative part, then about the cannulations done during mitral and aortic surgery, mitral and tricuspid surgery, particularly for minimal invasive, and then role of PE, the various complications associated, followed by the conclusion. Now, if you see the evolution of the cardiac anesthesia over years, in 1960, the cardiac surgery was done when the medical therapy was failed. And in 1960s or 70s, the high opioid anesthesia came. Then we have to post-operatively mandatory ventilate the patient because to stabilize the patient, to temperature management, to have the correct APG variables. Then reoperations were also quite common because of the bleeding. Then came the era of minimal invasive surgery. Now, what is minimal invasive surgery? It is a cardiac surgery, any cardiac surgery which is performed through a small chest wall incision that does not include a full sternotomy. That is minimal invasive surgery, and Kosogrov has done in 1996. First surgery already been described. Now, what are the various scope? We can do CABGs, we can do valve surgeries, we can do all sort of surgeries. Also, we can do redo surgeries as well. And in mitral and tricuspid, if we see, we can do various stenotic lesions repair, we can do replacement, we can do regurgitation of the mitral as well as tricuspid, and we can do both the replacement as well as the repair of the valves. Now, this is, if you can see the echo picture, this is medial 4-chamber view. You can see a mitral valve is deformed, is rheumatic. There's a deformity at the tricuspid valve also. You can see severe regurgitation is there, and this, you can see severe regurgitation at the mitral valve. These are the patients we can do with minimal invasive approach also. Mitral stenosis patients, we can also do, you can see a sac in the left atrium. How thick is the mitral valve? Is a rheumatic valve, and some TR is also there. We can do these type of mitral valve with minimal invasive approach also. Then isolated tricuspid lesions we can also do with minimal invasive approach, like isolated abstinent anomaly, or we can do along with the rheumatic lesions, we can do tricuspid repairs also. And we are doing around 60 to 70 MICS cases per year in our institute. That was in pre-COVID period. Now, if we see the review of literature, there are too many papers are there on anesthesia for minimal invasive surgery. It is the latest paper came in 2021 by Alexander White. Then one paper in BJ is also there from Parnell in 2018. Then from our institute, like from AIMS also, there is one paper is there about the anesthetic challenges. Then a surgeon paper is there. What should be the role of anesthetist in minimal invasive mitral valve surgery? This from the surgeon's perspective. Then there are various surgical papers are there on minimal invasive surgery, like they have found it's a safe technique with lower 30-day mortality and stroke rate. Then there endoscopic mitral and tricuspid surgery. There are so many papers are there. One like in redo surgeries also. It has been done. They have shown that it is also feasible and low mortality is there and strong patient satisfaction is there. Then in isolated redo tricuspid mitral valve surgeries have also been reported with minimal invasive approach. Then other right-sided lesions like tricuspid, ASD, myxoma, they have also been reported with minimal invasive approach. If you see our work, we have also done a lot of work in mitral valve redo surgeries. Like in redo surgeries, 32 patients in our previous institute in the squats we have done with right anterolateral thoracotomy and fem bypass. We have used both endoclamps as well as direct clamping of the aorta. Then we have done ASDs also. Then we have done we have done around 220 patients on minimal invasive mitral surgeries with good operating time and good minimal hospital stay. Then we have done around 800 patients of mitral surgery as well as atrial septal defect, and we found that we have the patient had faster recovery, have cosmetic advantage, and more patient satisfaction was there in these type of patients. Coming to the anesthesia considerations, although the previous speakers has already been described the like management of the patients in the pre, intra, and post-operative period, I will further give some things which were not covered previously. We have to do the history, the physical examination, laboratory investigations, imaging, and key points which are important, which are relevant for minimal invasive surgery. Like we have to look for the primary cardiac pathology along with that, like concomitant cardiac and vascular abnormalities. They are the most important thing in the cardiovascular system. Vascular system has to be examined. Like whenever we are clamping with endo balloon, we are using endo balloon, although it is not routinely used in our institute nowadays. But if we are using endo balloon, we have to evaluate the severity of aortic regurgitation. We have to look for the aorta, the dilatation of aorta, the effacement of the sinotubular junction. Any abnormality is there, then endo-aortic balloon is not used in those surgeries. Then T should be done, although already been described, the LV-RV dysfunctions, the presence of patent foramen ovale, the presence of LSVC is most important. We have to do another percutaneous cannulation or we have to convert the patient to open surgery. Apart from that, we have to look for any CRF, renal failure, hepatic dysfunctions, any history of stroke. That is also important for these patients. Now, peripheral vasculature I already shown that any plaque, any aneurysm, any dissection, any foreign material, any graft or stent, they are absolute contraindications for minimal invasive because you have to go on percutaneous bypass. This is an absolute contraindication of minimal invasive surgery. That is why CT angiography is mandatory in the pre-operative evaluation of these patients after any abnormality is detected on Doppler. So absolute contraindication is aneurysm of ascending aorta more than 40 to 45 millimeters. There is no defined sinotubular junction. We cannot use endo-aortic balloon. Then there is more than moderate AR, inability to use TE because of any problem, or mobile aortic atheroma. You can see in Ecg, the mobile atheroma is there in the aorta. You can see these type of picture. We should avoid minimal invasive surgery, and like these type of aorta, dilated aortic root more than 4.5 or 4, you can say 4 centimeters, then more than 2/4 AR, we should avoid minimal access surgery. Other contraindications which are not all like mitral annular calcification. Extreme mitral annular calcification is again a contraindication for doing minimal invasive mitral surgery. Otherwise, other like contraindication has already been described, like pectoralis excavatum or chest surgery, trauma, rib fractures, redo surgeries. Maybe in some redo surgeries we have to do sometimes tricuspid redo surgery. We have to do minimal access surgery. Morbid obviously is a relative contraindication. Now, coming to the respiratory system. The respiratory system is also very important for minimal access surgery. We have to look for risk of hypoxemia because risk of hypoxemia is there in these patients. We are doing one lung ventilation. We have to see whether there is suitability of one lung ventilation is there or not because we have to isolate one lung. Then we have to look for that. Then pre-operative echo with regard to the RV function is important. Like this type of picture in which the RV severe RV dysfunction is there, we should avoid minimal access surgery. You can see a D-shaped septum is there. The RV is hugely dilated in this picture. You can see echo picture. So we have to look for degree of pulmonary hypertension, the RV dysfunction, the predicted right ventricular pressure, size and functions. And although pulmonary hypertension as such is not an absolute contraindication for surgery, and we have to optimize the respiratory system. The values are important, already been described. FVC of less than 50%, FEV1 of less than 2 liters in values or less than 50% of predicted, PaCO2 or room air of more than 45 millimeter of mercury, and all these tests. And you should avoid one lung ventilation in patients, particularly with FEV1 of less than 50% predicted, PO2 on room air, PO2 of less than 65, PCO2 of more than 45, carbon monoxide diffusion capacity of less than 50% predicted, chest wall deformity, kyphoscoliosis, or then we should avoid, or severe morbidly obese patient. In those patients, we should avoid these. Another important is the GI system evaluation. Why it is important? We have to look for the contraindications for transesophageal echo because contraindication to TEE is a de facto contraindication to surgical procedure itself. Whenever we can't do TE, that means minimal access surgery is not possible because TE is mandatory for minimal access surgery. So any contraindication to TE is a de facto contraindication to minimal access surgery. Then musculoskeletal patient positioning is also important. Any problem with the musculoskeletal system, we have to properly evaluate the patient because we have to position the patient other than supine. Sometimes we have to write the hemothorax is elevated. We have to the right hand should be tucked by the side. So any injury to the nerve injury is also possible in these patients. And particularly the surgical issues are there, like morbidly obesity with large breasts, particularly the female patients, because we have to use high flow in these patients, particularly on bypass. Then chest wall deformities have already been done, and size of femoral vessels for cannulations is also important. So these type of patients, like morbidly obese patients, female patient with large breast, or kyphosis or scoliosis, or with peripheral vascular disease, these are the patients we should avoid doing minimal access mitral valve surgery or tricuspid surgery, or any mitral minimal invasive surgery in these patients. Coming to the intraoperative management, the induction and conduct of anesthesia is same, follow the same principles as that of other like for open surgery. The anesthetic consideration for mitral or tricuspid will remain same as for minimal access surgery. Only difference is we can use the short-acting drugs in these patients because we have to do the fast tracking in these patients. Otherwise, the WM endotracheal tube or bronchial blockers or simple endotracheal tube we can also use. We can ask the surgeon to cooperate with the anesthesiologist while manipulating, or while you can put a sponge and to press the lung, and we can even use a simple endotracheal tube. The position of defib pads is like they are a must for minimal access surgery. External defibrillable pads, the EKG, the electrode placement for ECG, the IV line accessibility, and the padding of pressure points has already been done. We have to properly place the pads, and we have to look for we should always check the ECG after putting the defibrillator pads. Now, anything we can use for one lung ventilation, bronchial blockers or double lumen tube, and we can one lung ventilation. Some things are like we have to airway pressure will increase. We have to manage accordingly. We have to use small tidal volumes. Then all these problems are there with one lung ventilation: decrease FRC, decrease lung compliance, atelectasis, increased shunt flow. Then other hemodynamic problems are also there with one lung ventilation. There is increased CVP is there, filling pressures is there, decreased venous return is there. There will be ultimately decrease in the cardiac output, decreased mixed venous saturation. There will be increased PaCO2 will be there. So these are the problems which are also there with the one lung ventilation. Sometimes increased ICP is also there, and so we have to give FiO2 of 100, already been done by the previous speakers, CPAP to the non-ventilated lung or PEEP to the ventilated lung. Monitoring, routine monitoring is used in all these patients. Apart from that, the important thing is, like we have to, whenever we are using endo balloon in these patients, we have to use bilateral radial artery cannulation, because if any misposition is there in the endotic balloon, the right radial artery will show like there is a deformity in the right radial pressure. And we have to use more than 2 transducer in these patients. Whenever we are using endo balloon, we have to monitor the pressures. 2 arterial pressures are monitored, and 1 more pressure for plagia is used. So we have to use 3 or 4 pressure transducer in these patients, and that is quite cumbersome for us. And we have to manage accordingly. And TE is must, and NIRS is also one of the important tools in these type. Apart from that, we have to do routine monitoring in these patients. And coming to NIRS, sorry. This is an important monitor which is used intraoperatively. And these are the electrodes we place on the forehead for the hemispherical, cerebral hemisphere monitoring. And this is the values like right, left, and the right hemisphere. Now, why it is important? Because whenever we are going on the peripheral bypass, the arterial blood is returned into the abdominal aorta, and the blood supply to the upper body occurs in a retrograde fashion. And whenever, as already been described by ma'am in the previous talks also, and whenever the heart is not fully depressed, and there is the patient is still on bypass, but it is ventilated and non-ventilated, and still beating heart is there. There's a mixture of the blood is there, and there is a differential hypoxia of the upper body tissues is there, and that may be reflected as hemicerebral ischemia. And there may be one right hemicerebral ischemia will be there, and the value of the right cerebral oximeter will be decreased. So we have to give 100% oxygen during that time, and we have to immediately do the diastolic arrest of the patients to have a proper cerebral functions. Positioning is important. We have to neck, arms, and legs are not hyperextend or hyperflex to prevent the injury. And this is the routine, positioning is there in mitral valve surgery and tricuspid surgery. The right hemithorax is slightly elevated. And usually what we do, we will put an inflatable bag inside the right hemithorax, and we inflate the bag whenever the positioning is to be done, and after the surgery we deflate the bag. And the padding of the pressure points is also important. And this is usually the surgical procedure through the right thoracotomy. And what is the important thing is the cannulation in these patients. We have to do arterial and venous cannulation for bypass, venting, and delivery of cardioplegia. And why? What is the role of anesthesiologist in this case? Whenever we are doing if we are doing a mitral valve surgery and we are not opening the right atrium, then we have to put a single venous cannula, which is a single two-stage venous cannula, and it goes to the femoral vein, to the IVC, and goes up to the SVC. And whenever the right atrium is to be opened, then we have to place two cannulas. One is through the femoral vein to the IVC, and the other is the SVC cannula, which is placed by in our institute, is placed by the anesthesiologist to the right internal jugular vein, just above the right atrium SVC junction. Here comes the important role of the anesthesiologist and the role of TEE. The SVC cannula is placed into right IJV under ultrasound guidance, and after putting the guide wire in the right atrium, in the SVC, we have to give around 1 milligram per kg of heparin. Then after waiting for 3 minutes, we have to put the cannula under ultrasound guidance, and IVC cannula is placed by the surgeon after full heparinization. And the role of T is very important, and we have to use the centrifugal pump in these patients because we have to do the vacuum assisted drainage for venous drainage. And these are the cannulas we use. This is the SVC cannula, which plays into the right IJV. This is the IVC cannula, and these are the stillet for those both the cannulas. This is the SVC cannula, and this is a long guide wire is used for SVC cannulation. Now, this is how we place. This is the ultrasound probe, and this is how the guide wire is checked into the right IJV. Then it is dilated, and then the cannula is placed. And we have given heparin about 50 milligrams, like 1 milligram per kg at that time. We wait for 3 minutes, then place the cannula, and the surgeon will pass a bypass, like SVC drainage, like line from the surgical side to you, and we will have to connect that SVC drainage to the SVC cannula, SVC venous line. And this is how sometimes we have to place both the lines on the same side if it is not possible. Otherwise, in our institute, we are using right IJV cannulation for SVC cannulation, for SVC drainage cannula, and the left one is used for CVP placement or the central venous placement. And this is the femoral artery cannula, which is placed by the surgeon after full heparinization, either by the direct cut down or Sendinger's technique or by end-to-side graft, depending on the size of the vessel. And this is a picture showing the arterial and the venous cannula. This is the venous cannula into the femoral vein, and this is the arterial cannula in the femoral vein. And the role of T is very important. We have to check the position of the guide wire. We have to check the position of the cannula into the right atrium. Now, you can see this is a mediasophageal bicable view. You can see a guide wire in place. At this time, the anesthesiologist role comes. We have to check whether the wire is there in the right atrium or not. We have to confirm with the surgeon, confirm to the surgeon that the guide wire is there in the right atrium. Then we have to check the position of the cannula. You can see this is a drainage cannula. In this patient, we have used only single cannula because mitral valve is to be replaced. The cannula is in the right atrium, and it is going towards the superior vena cava. Here we have to check. Then we have to check the cannula into the IVC. Now, how we check? We check. This is the IVC. You can see a cannula into the IVC. It should be just distal to the cavo-atrial junction into the right atrium. This is the hepatic vein. Again, we have to confirm the position because it should not go into the right atrium whenever we are opening the right atrium. The IVC cannula and the SVC cannula should not be visible into the right atrium. And this is a view. This is the descending thoracic aorta. We have to check the position of the guide wire whenever we are putting the arterial cannula in this. And this is an important paper from AIMS. What is the role of transesophageal echo in minimal access cardiac surgery? They have shown that it's already been described that AR severity, to assess the aortic's root and the ascending aorta, the atheromatous disease of the aorta, PFO, ASDs, guide the end-aortic balloon positioning, then to guide the additional lines like PA vents. Sometimes we have to put the pulmonary artery vents or the coronary sinus catheter for cardioplegias. Then we have to check the complications associated like erroneous CPB placement, which is devastating. Then perforation, any perforation of right atrium or ventricle, any inadvertent cannulation of the hepatic vein instead of IVC, any distension of LV distension is there, or any new onset of AR can also be detected. So this is the role of transesophageal echo in minimal access surgery. The bypass management, after putting the cannulations, we have to go down bypass. And although the bypass management is almost same as that of routine cardiac surgery, only thing if we are doing the isolated tricuspid valve surgery, then we should not clamp the aorta. We can also fibrillate the heart, or we can done on the beating heart also. Whenever doing the mitral valve surgery, we have to clamp the aorta. How we clamp the aorta? There are two methods for clamping the aorta. Either by putting a clamp, direct vision by the surgeon, or by the endoballoon. First is by the, which is used quite commonly in our institute, is the Chitwood clamp. It is placed in the third intercostal space by the surgeon under direct vision through a separate small chest wall incision. And whenever the aorta size is less than 45, the aorta size should be less than 45 millimeters. And the cardioplegia is also, cannula is also placed directly into the ascending aorta. And after putting the clamp, the cardioplegia is given. This is a Chitwood clamp which is used under direct vision. It can be placed onto the aorta through a separate incision. Now you can see in this picture, this is a Chitwood clamp which is placed into the third intercostal space, directly clamping the aorta. And this is the vent line which is used on all the. It's basically the cardioplegia is given through this line, and after before coming off bypass, it is also used as a vent. Now this is the paper from Leipzig. They have also used this type, like this cannula is used for cardioplegia, and the vent is also used through this line only. If the second method of cross clamping of aortic cross clamping is the endoballoon. It is done either through the femoral artery or the subclavian artery. Again, the role of T is very important, and the inflation of balloon is slightly deformed. So it forms a tight seal inside the aortic wall, and it prevent the systemic leakage of the cardioplegia. Although it's a quite cumbersome technique, that we have to monitor the pressures, we have to use 3 or 4 transducers in these patients. And the other problem is that whenever the abnormal anatomy of the aorta is there, it is not indicated. And this is the endoballoon which is used. This is how it is placed to the femoral arterial line, to the side port. Then the role of T comes. We have to check the proper position of the aorta. This is the proper position of the endoaortic balloon, and this is, you can see the jet of the cardioplegia going through the coronary arteries. And we have to check the position of is important. This is the ideal position of the endoballoon, and whenever the distal migration is there, that is why we have to put the right radial cannulation in these patients. There will be obstruction of the innominate artery. It will show the right radial pressure will suddenly decrease. And if there is a proximal migration is there, the cardioplegia will not be delivered properly. So this requires the attention of the anesthesiologist, because we have to monitor the position of the cannula as well as the pressures of the endoballoon. Another important thing, which is retrograde cardioplegia, it is also not routinely used in our institute also. It is used for delivery of cardioplegia, particularly for minimal access surgery. Although in routine surgeries, we are using retrograde cannula for every patient, but for minimal access surgery, we are not using these. Just for theory point of view, the delivery of the cardioplegic solution through the retrograde, like coronary sinus, and this is a cannula which is used through the IGV, and it is it's a 9 French 57 centimeters cannula which is used, and it is used for the occlusion of the coronary sinus, and ultimately to give monitor the coronary retrograde cardioplegia. And this is a general, this is a retrograde coronary sinus, and this is a picture from echo image from the routine surgery, and this is how we can look for the placement of the retrograde cardioplegia cannula in our patients. Another important catheter is the endo vent, which is used as a PA vent, which is percutaneously placed through the interjugular vein. This is also not routinely used in our institute. It is a thin-walled 8.3 French catheter. It is designed for high flow rates to ensure adequate venting of the patients. So this is also not routinely used. Just for the theory point of view, it can be used in the minimal access surgery. Weaning from bypass, particularly in minimal access surgery, is same as that of conventional surgery. The important difference is de-airing. The de-airing is not possible adequately in minimal access surgery. So it should be TE-guided, de-airing should be done. And the role of carbon dioxide insufflation comes here, because the carbon dioxide is more soluble than air, it is heavier than air. So continuous insufflation of carbon dioxide is very important at the time of de-airing. To have a proper de-airing, we can shake the table on both the sides to have some help in the de-airing. And we can place a pacing lead beforehand in these patients if there any arrhythmia occurs. The post-CPB management is also important because we are giving protamine in a closed chest scenario. The chest is not completely open, so we have to ready for protamine reaction in this type of scenario. And then we have to, the important thing is, another important is the SVC care of the SVC cannula. We give, we have to press the SVC cannulation site for 10 to 15 minutes to have an adequate hemostasis at this site, because the risk of hematoma is also there. Extubation, we have to use the fast tracking protocol, the DLT. If we are not mentally extubating the patient on table, the double lumen tube should ideally be replaced with a single lumen tube. And fast tracking is done by short-acting drugs, normothermia, non-narcotic analgesia has already been described. The regional technique is also important, like intrapleural, epidural, paravertebral. Nowadays, serratus anterior, erector spinae, pectoral now. Basically, the aim is to decrease the pain in the post-operative period. Any technique can be used in these type of patients. We have also used compare the thoracic, epidural, and paravertebral blocks in robotic-assisted CABGs and find equivocal results. Routinely in our institute, we are using intrapleural anesthesia. We ask the surgeon to place our normal routine epidural catheter percutaneously into the surgical, like intrapleural space, and intermittently we can give ropivacaine in these patients. About 8 hourly, we can give 20 ml of 0.5% ropivacaine. But the important thing, at the time of giving ropivacaine or local anesthetic, we have to clamp the this drainage, because if we are giving continuous infusion through this line, then there will be continuous leakage will be there. So we have to clamp the line, clamp it for 20-25 minutes, then we have to give the drugs, and then clamp it for again. After giving the drugs, we have to clamp it for 20-25 minutes, and it is quite effective techniques in our experience. Coming to complications, as already been described, the most important complication of any minimal access surgery is the conversion. The conversion is around 1% reported in the literature, and the most important indication for conversion is the inadequate access and the bleeding and the pleural adhesions. These are the three things which are looked for, and whenever the conversion is there, then the chances of mortality is also increases in conversion group. Another is the post-operative bleeding. There may be, because of the incompletely open pericardium, because of the posterior collection of the blood, there may be hidden bleeding may be there. So sometimes we have to diagnose with repeat T of the patient in the post-operative period. We have to sometimes do VATS. If it is not treated, then we have to reopen the through thoracotomy or through sternotomy to have to address the bleeding. The important complication is related to the peripheral cannulations, because that is because we have to do the percutaneous bypass in these patients. The incidence of stroke is quite frequent as compared to open surgeries, 2.1 to 1.2%. Aortic dissection is also there as compared to open surgery. Another important complication is the femoral compartment syndrome. Then femoral arterial pseudoaneurysm is also 1 to 6%, and hematoma at the SVC cannulation. So whenever we are putting SVC cannula, we should always care that area. We have to look for any hematoma is there or not. Problem associated with positioning, like brachial plexus injury, is also quite common. Phrenic nerve damage, because we sometimes surgeon open the pericardium too posteriorly, that may cause phrenic nerve damage. Ulnar nerve compression is also there. Problem associated with one lung ventilation, like acute lung injury, air leaks, segmental collapse, re-expansion pulmonary edema is also around 2.1% incidence is there, and may increase some mortality in the post-operative period. Just to conclude my talk, that minimal invasive mitral and the tricuspid valve surgery is technically challenging job. Role of anesthesiologist is crucial, as it requires expertise in the field of one lung ventilation, the TEE, regional anesthesia, and the fast tracking in these patients. Patient selection is the most important prerequisite. Proper patient selection is most important thing, and the TE is mandatory. TE has a definitive role in the pre, intra, and the post-operative period, and contraindication to TE is a de facto contraindication to minimal access surgery of any kind. And the close coordination between the team is also very important. Thank you.
Thank you, Dr. Arora. It was a fantastic talk, very engrossing, especially for, I think, the postgraduate residents and a lot of us who have not seen many of these minimally invasive surgeries. Also, I think in no uncertain words, you reiterated the fact about the TE. I think it's an important armamentarium. I mean, to have in our armamentarium is important skill to have in our armamentarium, and I think very important for all of us to move ahead with times and acquire this skill. I think one also important point with the TE is that it helps us to guide in the decision towards the end of the surgery in terms of the prosthesis mismatch. So I think that's something that will be also a valuable input that the anesthetist provides. Other than that, I think the TE is like a night vision now in these times of minimal invasive surgeries. So I think, thank you, sir. It was very, very engrossing, like I said.
Thank you.
And I really look forward to hearing more from you soon. Thank you, sir.
Thank you. Thanks.
Over to Dr. Selva for the next speaker.
Yeah, thank you. Thank you, Dr. Vishwas. Now we'll move on to the third lecture in session 2. Now the speaker is Dr. Sudarshan Shetty. The topic is minimally invasive aortic valve replacement. Now the TAVI is taking up its own path. So if you want to compete with TAVI, we should do this minimal invasive aortic valve surgery to attract the patients. And Dr. Sudarshan Shetty is a very eminent person. Currently is working as Director of Perioperative Ultrasound in Department of Anesthesia at University of Minnesota. And his special interest in ultrasound resident and teaching the fellow educators, fellow students in the University of Minnesota. And now I request Dr. Sudarshan Shetty to take over and move on to the next lecture. And please kindly try to keep your time schedule, sir. Thank you. Please go ahead, sir.
Thank you, Dr. Selva. Can you guys hear me?
Yeah, sure.
Great. All right. I would like to thank Dr. Sarkar and the organizing committee for inviting me to this webinar. I'm going to start my screen sharing here. Can you guys see this?
Yeah, it's clear.
Awesome. Okay. Make this big. All right. My name is Sudarshan Shetty. I'm an associate professor and as Dr. Selva said, interested in point-of-care ultrasound and ultrasound education. I have no conflicts of interest. And these will be the learning objectives for today's talk. Brief introduction to the minimally invasive aortic valve surgery. The previous speakers have done a tremendous job of giving a great overview. We will go over a little bit about the surgical procedure. How is this important to the anesthesiologist, and how is the minimally invasive aortic valve replacement? Is it better than conventional sternotomy? And we'll look at a little about the evidence as we go along. So what is minimally invasive cardiac surgery? Depending on who you ask, the definition is different. The Society of Thoracic Surgeons, they say it's any procedure that's not performed with a full sternotomy and full cardiopulmonary bypass support. And this is their verbatim definition. The American Heart Association says it's small chest wall incision that does not include a full sternotomy. And how common is this? In a paper from 2017-2018, they found about 20% prevalence of all aortic valve replacements in USA were minimally invasive, about 30% in Germany. And what's the advantage of doing a minimally invasive aortic valve replacement versus a standard sternotomy? So I did a brief survey. I spoke to a few surgeons in our institution and whoever I could reach over the phone. And not surprisingly, this is what I heard from most of them. Surgical trauma is less, the recovery is faster, and it's better suited for obese patients, better suited for patients with COPD because the duration of ventilation in the ICU is shorter. But is that really true? Let's see. So this is a busy slide. I don't expect you to read everything here.
Sir, excuse me. Can you make the screen as full screen? Can you press the button?
What are you seeing now?
We are not able to see the full screen.
Okay. How about now?
Now it's right. Right, sir. Thank you, sir.
All right. So busy slide. I don't expect you to see all the details here. Okay. Can you see this now?
Yeah, we can see, but it's very small. Yeah.
This one is small?
Okay. Okay.
Okay. So this is a brief synopsis of like why minimally invasive AVR is like better. And if you see like the first line, these are all retrospective studies. Some of them are propensity matched, some of them are not. And in the comments, they've talked about like why this is better. And mostly these are the conclusions. Lower post-op complications. The outcomes are better if you choose like patients with preserved ejection fraction. The transfusion requirements have gone down, and the ventilation time in the ICU is shorter if you use minimally invasive aortic valve replacement. So, but the Cochrane database on minimally invasive aortic valve replacement, this is their conclusion. The quality of evidence is low to moderate. The sample sizes were small and underpowered for events that had like a low incidence. There is some evidence to support that there is a reduction in the hospital length of stay. And as usual, they said like we need better designed RCTs and studies that are like more adequately powered. But in my experience, this is true. I also take care of these patients in the ICU post-op, and minimally invasive cardiac surgical patients, like they do much better, like they stay in the ICU for a shorter period of time. But of course, there's a lot of bias involved in this because we choose like patients who are like a little more healthier, and the duration of bypass is shorter, and so on and so forth. One of the questions that's been asked is, how does the minimally invasive aortic valve replacement compare with TAVRs? Nowadays, like TAVR is getting more and more prevalent. And this is a comparison between TAVR and minimally invasive aortic valve replacement. The patients who had TAVRs in general had a lower post-op stay duration, lower incidence of AKI, but a higher mortality at 1 year. The paravalvular leak was higher with TAVI compared to the minimally invasive aortic valve replacement, but the 30-day mortality, bleeding, and stroke risk is the same. What we need to remember here is this is a comparison of the data from 2002 to 2019. And earlier in the day when we started doing TAVIs, the patients were like much sicker, and this was considered like a bailout option for people who were like not really surgical candidates. I'm sure that plays into the overall increased mortality with TAVI at 1 year. And how do the surgeons approach these patients? What are the surgical options for like doing the minimally invasive aortic valve surgery? We have a couple of options. One is the mini sternotomy, which looks exactly like the regular sternotomy, but like stops short. It's about like 5 to 6 centimeters. And some of them add a J-shaped incision. They extend the incision for like better access. And then there is the right anterior thoracotomy, which is in the 3rd or 4th intercostal space, again, like 4 or 5 centimeters. And which one is better, mini sternotomy or mini thoracotomy? And this is a study like where they looked at about 2,500 patients between 1999 and 2019. Again, retrospective analysis with propensity score matching. They found the outcomes were much better with mini sternotomy as compared to the mini thoracotomy. And we saw a couple of approaches that the surgeons can take between the right anterior thoracotomy and mini sternotomy. And how does a surgeon decide like which approach to take? This is where like the pre-operative testing comes into play. And this is where like we can engage the surgeons and talk to them about like which approach to adopt. So apart from the routine pre-operative tests that we do for any other cardiac surgery, when you talk about minimally invasive aortic valve replacement, the CAD scan plays an important role. Here is a couple of images from a pre-operative CAD scan. And so there are a few criteria that the surgeons use to decide if the patient is suitable for a right anterior thoracotomy. If like more than 1/2 of the ascending aorta is on the right side of the right parasternal line, and the skin to ascending aorta at the PA bifurcation is less than 10 centimeter, or the angle between the midline and the ascending aorta axis is more than 45. In a sense, what they're trying to see is, if they do a right anterior thoracotomy, how easily can they access the ascending aorta and the aortic valve? And as anesthesiologists, what is it that we need to consider for these patients? And this has been brought up a few times in this webinar before. Because of the small size of the incision, the surgeon may or may not be able to use like internal defibrillator paddles. So we need to make sure that the patient has external defibrillator pads, and not always possible to place epicardial pacemaker leads. And if the patient goes into some kind of heart block that needs pacing, you should consider like transvenous pacemaker. And multimodal analgesia, the ERAS pathways in cardiac surgery is like picking up steam, though not completely like evidence-based, but I know we're all doing that, trying to collect more evidence. And that requires a fair bit of planning. We have to plan for lung isolation, double lumen tube, or if it's a single lumen tube with a bronchial blocker, and intraoperative TE. It has been emphasized like enough. I'm not going to go into like further details about that, but yes, any valve replacement, if you look at the AAC guidelines, it's a class 1 indication to do a TEE. Apart from those, we need the TEE to like guide the surgeon for cannula placement and for going on to cardiopulmonary bypass and for retrograde cannula placement. So the delivery of cardioplegia becomes a little interesting in these patients with mini sternotomies. Because the access is so small, the surgeons usually struggle to get the cannula in, where this is where we can help them with our TEE expertise. Sometimes like they will open up the aorta and start infusing the cardioplegia, antegrade cardioplegia through the coronary ostia directly, or the retrograde catheter is placed. Another consideration is the Del-Nido cardioplegia. This is more prevalent in the pediatric population, but it has been used in minimally invasive aortic valve surgeries. The composition is a little different, but the advantage is that it lasts a long time, and we don't need to like keep bolusing at 20-minute intervals. And you won't hear the perfusionist keep reminding the surgeon that it's close to 20 minutes after their previous dose of cardioplegia. Just for like people who are in their post-graduation, like this is the difference between the Del-Nido cardioplegia and the standard blood cardioplegia. In this particular study, which had only about like 46 patients, 25 of them had the Del-Nido cardioplegia. The incidence of ventricular fibrillation was smaller with the Del-Nido cardioplegia. And the intraoperative blood glucose levels are also like much better. And why would the surgeon like need to convert to a full sternotomy? The conversion rate, like according to this study from 2018, is 3%. And the usual reasons are like difficulty with arterial cannulation, adhesions to the lung, difficulty in visualization of like the aorta, or if you get into bleeding, that cannot be controlled with the short incision that they have, they'll have to probably extend that. So our approach in our institution, this is what we do. Pretty much everybody gets preoperative acetaminophen, like a gram of Tylenol. And as part of the multimodal analgesia, we use like regional catheters, paravertebral or electrospinal catheters. Intraoperatively, they all get like an arterial line and a flow track to monitor the cardiac output index, stroke volume index. And to assist with the pain management, we use low-dose ketamine drip, 5 to 20 milligrams per hour, and dexmedetomidine drip. If the patient meets all criteria for extubation, we try to extubate them at the end of the surgery. And in select patients, sometimes they'll need like a little bit more support after extubation. Then we use non-invasive ventilation as a bridge to transport them to the ICU and like keep them in the ICU on non-invasive ventilation for a few hours if necessary. So regional anesthesia for cardiac surgery, again, like much talked about, but what is the evidence behind this? Paravertebral catheters, very popular. Some say like it's as good as epidural catheters, but the effectiveness is not well studied in cardiac patients. What about erector spining? Again, effectiveness is not well studied. We don't have like large studies to look at this. Serratus anterior plain block, effectiveness is not well studied. That's a study from Current Opinion Anesthesiology that talks about this. And this is CT of the chest where like you see, this is the area where we usually place catheters in our institution, the paravertebral and the erector spining catheters. It was interesting to see the previous speaker talk about interpleural catheters. And yeah, in our institution, like we use the paravertebral and the erector spining. So in general, does regional anesthesia help? This is not about minimally invasive cardiac surgery. Does it help in cardiac surgery itself? Paper from Anesthesia Analgesia from last year. They took like 451 patients who received like either more than 50 morphine sulfate equivalents or less than 50, and there was a group which received less than 25. So for conversion, one morphine sulfate equivalent is about like 10 mics of fentanyl. They all got like preoperative adjuncts like gabapentin, Tylenol, ketamine, dexmedetomidine, and regional analgesia by the serratus anterior plain block. They did find a reduction in the intraoperative opioid dose, but there was no significant difference in outcomes when you compare the high to the low and the high to the ultra low groups. So we still don't know, but anecdotally, it does help. A couple of case studies for the cases that we did with the minimally invasive approach. Our first patient was a 62-year-old male with a past medical history significant for COPD. He was morbidly obese, low EF, end-stage renal, and he had recent shortness of breath due to suspected infective endocarditis of the aortic valve. Pre-Operative Cad Scan was not suitable for a right anterior thoracotomy. The COPD was not that bad, but the person was like on the bigger side, so we chose to do a mini sternotomy, and we went on like central cannulation. He got multimodal analgesia with erector spining, ketamine, Presidex. We gave only about 300 mics of fentanyl for the 6-hour procedure, along with like 0.5 milligram of hydromorphone. Some images from that patient. So as you can see, like the EF is not that great. And the aorta is slightly dilated there. And this is where you see like the regurgitation, moderate regurgitation, which was worse in the preoperative transthoracic echo. And that's the retrograde cannula placement. The surgeon struggled because it was a small incision. And here you can see that's the placement of the retrograde cannula. So we recorded the one image that where the surgeons were successful. They had to try a few times before this. So it's not always easy to place the retrograde cannula with a small incision. And this is the post-bypass image. There's a 25 millimeter Edwards aortic Resilia bioprosthetic valve in place. The surgery itself like went pretty well, but the EF worsened and the patient needed like intra-aortic balloon pump overnight for a low cardiac index along with some epinephrine. He got hemodialysis the next day and he was extubated. Second patient, 61-year-old male with bicuspid aortic valve, severe aortic stenosis with preserved LV function. The past medical history was significant only for hypertension. So we chose the same pathway, mini sternotomy, multimodal analgesia. We put in a large for central venous access in the right IJ, arterial line, no Swan-Ganz catheter. We usually place a Swan-Ganz catheter on pretty much all our patients because our ICU nurses are really used to like managing patients with Swan-Ganses, because we are big on heart failure and transplants in our institution. We chose not to do that in this particular patient. The patient did great, extubated on table, transferred out of the ICU on post-op day 1 with minimal pain. So some images from the severe aortic stenosis patient. That's a bicuspid valve there, short axis view. Long axis view with flow acceleration seen there. And that's the retrograde cannula placement. Again, the surgeon struggled. Here's a retrograde cannula in the coronary sinus. This is the bioprosthetic valve after placement. Patient had low gradient and the surgery went great. So this is a short video of the surgical steps of mini AVR, mini sternotomy aortic valve replacement. It's about 3 minutes. I think I should have enough time. I'm going to pause in between just to talk about like the steps. I think this will be useful for the postgraduates in particular. So the surgeon is making an incision here. As you can see, like it's pretty small, almost like an incision that people would make for an appendectomy. Achieving hemostasis. They'll do the sternotomy next. There the sternum is exposed. That's the sternotomy. Again, you can see like the incision is, sternotomy is like pretty small. They're going to achieve hemostasis again, like after the sternotomy. And I'm going to pause it here. So this structure here is the right atrial appendage. That's what they're going to cannulate for the venous access. You can see like your venous access here, the arterial cannula and the antegrade cardioplegia cannula there. Is going to place that's the aortic cross clamp going on. That's the cross clamp. And then he's doing the aortotomy to look at the valve. And then he's going to excise the valve next. That's the aortic valve coming out. He's going to like start measuring the annulus there. Different sizers for the aortic valve. Getting ready to place the aortic bioprosthetic aortic valve. That's your bioprosthetic aortic valve with a sewing ring there. That's going to go in there next. Checking to make sure all the sutures are intact. And then he's closing up the aortotomy there. Achieving hemostasis, and they'll start like decannulating soon. So here you can see all the cannulae are out. The aortic cannula is out. The venous cannula and the right atrial appendage is out. The antegrade cannula is out. And once they're happy, the chest is being closed. So as you can see, like it's possible to do the entire like aortic valve replacement like in this short incision. The only difference is like the size, and like the surgeon needs to be a little more skilled to do this like in small spaces. So in summary, minimally invasive aortic valve replacements, they're not that prevalent, but I think like competition with TAVIs is going to increase now that we are doing TAVRs on like patients who are much healthier, and this is not a last-ditch effort to save the patient who are not surgical candidates. And sutureless valves are coming into place now. This may be the future. So in a sense, like it's like doing a TAVR, but instead of like going through the aorta kind of endovascularly, the surgeon does an aortotomy through a minimally invasive approach, right anterior thoracotomy or mini sternotomy, and it saves them the time it takes to like suture the valve in. So once the aortotomy is done, like they just deploy the valve. That will save about like an hour on pump. So these will be like pretty quick procedures. And multimodal analgesia is promising, including regional anesthesia to like prevent opioid overuse and shorten the duration of hospital stay. And as other people have emphasized in this webinar earlier, requires a lot of like planning across multiple disciplines, including the surgeons, anesthesiologists, even the nurses, because these are a little more complicated than what we do, and the low prevalence, you need to be a little more vigilant. I would like to thank a few surgeons in our facility, Dr. Wohler, Schaefer, and Azmat Mohammed. They provided some feedback and video for the presentation. And this is our hospital. Minnesota, like if people are not familiar, it's in the northern part of the Midwest USA. Sometimes it gets really bitterly cold and goes down to like minus 45 degrees Fahrenheit. But it makes for like some really beautiful sunrises and sunsets. This is a sunrise just outside our hospital in early spring. Any questions?
So far, there is no questions in the chat box. So it's really good lecture. I think it's very useful in young patients, obese, with all suitable criteria for these procedures. And I think it is the only way to compete with our interventional cardiologists in future. I remember 10 years back when the drug-eluting stent was introduced, cardiologists spoke in a meeting that in another few years, there will not be any role for cardiac surgeon and anesthetist. Immediately, I got up and said, even if you do all the procedures in cath lab, still you need cardiac anesthetist and we can still survive, at least as a standby anesthesiologist. So in future, I think this is the technique to cover the patients or to market the patients that this procedure is on par with interventional procedures. It is very important to know that it's a multidisciplinary approach. Pre-op to post-op, we all should be together, like surgeon, anesthetist, and perfusionist. And you also mentioned, you also thanked your surgeon in this lecture. I really appreciate that. And this is the way we should be cordial with our team people. I think there are no questions in the chat box till now. And these are all well-chosen lectures with all eminent speakers. We should really thank Dr. Manjula Sarkar Prasanna and the team members for organizing this. Dr. Prasanna, anything more to say, or we'll wind up this session?
There is one question which says, for mini sternotomy, do you place a bilateral or a unilateral paravertebral block catheter?
Okay, can you hear me?
Yeah, we can.
All right. So we usually do bilateral paravertebral blocks. If you think about it, the common notion is sternotomy doesn't really hurt that much. So the paravertebrals, it offers analgesia not just for the sternotomy, but also for the chest tubes. If the pleural cavity is open, or like if you see like any pleural effusions, the surgeons will place chest tubes. It does help with chest tube pain too. And we do like usually bilateral paravertebral blocks. If it's a mini thoracotomy, that's a different issue altogether. Then we usually go only for the right side.
Okay.
Prasanna, over to you.
Okay, so I'd like to wind up this session. So thank you to all the three speakers. Thank you, Dr. Dheeraj. Thank you, Dr. Sudarshan. Thank you, Dr. Pushkar. And I'll also thank the two moderators, Dr. Selva Kumar and Dr. Vishwas Sate, for moderating this session. So thank you all five of you. So we now start with the pediatric session, and to moderate this session, we have Dr. Rahul Guha Biswas. He is the Zonal Academic Coordinator of Narayana Health East, a Senior Consultant, Department of Cardiac Anesthesia and Critical Care at the NH Rabindranath Tagore International Institute of Cardiac Sciences. He is also the President of IACTA West Bengal branch and also the Training Center Coordinator for the American Heart Association Emergency Cardiovascular Care Program. His areas of interest include transesophageal echocardiography and cardiovascular critical care. And to co-moderate, we have Dr. Jayashree Kore, who is a consultant cardiac anesthesiologist. She does both adult and pediatric cardiac anesthesia, and she's currently working at the Bhai Jarbai Wadia Children's Hospital. Thank you, Dr.
Okay, hi. Thank you, Dr. Prasanna, for a very kind introduction. And I will take the program forward. And at this point, good evening, everyone. At the outset, I want to thank Dr. Manjula Sarkar, the D.Y. Patil University School of Medicine and Hospital, and the Association of Cardiovascular and Thoracic Anesthesiologists, Mumbai, for organizing this extremely relevant and contemporary seminar. It's a great opportunity to be able to participate in this webinar. Tonight, I'm delighted to introduce Dr. Benjamin Clausel, who's one of our esteemed speakers. Dr. Clausel is Assistant Professor of Anesthesiology, Division of Pediatric Anesthesiology at the University of Minnesota, Masonic Children's Hospital. He is also the Director of Simulation Education for the residents in the Anesthesia Department. Welcome, Dr. Clausel. Even though the practice of minimally invasive cardiac surgery in adults is widespread in most of the reputed cardiac centers in India, I agree though with a lot of practice variations, MICS programs in the pediatric population are yet to gain a strong foothold across the country. And for this reason, we have a great opportunity here listening to Dr. Clausel and getting valuable insights regarding this important advancement in pediatric heart surgery. So, Dr. Clausel, the stage is all yours, and you may begin your presentation now.
Thank you very much for the nice introduction, Dr. Biswas. I'm going to share my screen here. Can everybody see that?
No, not yet.
No, not yet.
Yeah, just a second. How about now?
Yeah, we can.
Perfect.
Okay. Perfect. So let me okay, so thank you very much again for the introduction. And I would like to thank ACTA Mumbai, the organizing committee, and Dr. Sarkar for the invitation and the opportunity to talk at this seminar. And in my presentation today, I would like to talk about minimally invasive cardiac surgery in the pediatric population. And while my preceding speakers were focusing on specific areas of minimally invasive surgery in adults, I will today try to give you a little more general overview of the current stage for the surgical approach in children. And when you consider this area, like Dr. Biswas just mentioned, our field is lagging behind a little bit in comparison to the adults. And this is essentially because of three reasons. So one, the size of our patient population, and I mean not the patient population size, I mean the actual size of our patients. Second, the heterogeneity and the complexity of the anatomic lesions in congenital heart disease. And then 3, the availability of appropriately sized equipment. And in fact, if you asked a congenital cardiac surgeon 20 years ago about minimal invasive techniques, there's a very good chance that you would get an answer along the lines, yeah, we're not doing this, and we're not really sure if this is going to come up anytime soon. So I'm really excited about the fact that today I can actually tell you a good amount about procedures we are able to do in the pediatric population. And I, just as a disclosure information, I have no financial relationships or conflicts of interest to disclose. So for the objectives of my talk, first of all, I would like to define the term minimally invasive cardiac surgery, and especially how it relates to the field of cardiac congenital heart disease. Now, then I would like to provide an overview of minimally invasive approaches in congenital heart disease that have been reported. Part of them are performed at our institutions, and part are reported with good results in the literature. And then lastly, I want to go as a case-based study into selected procedures that we have performed at our institution, and highlight a couple of the major anesthetic implications and management in regards to that. Okay, so most congenital heart surgeries are performed through a full median sternotomy. That's essentially the gold standard, what we're all familiar with. Advantages, it provides excellent exposure. You have good access to all the different structures that you need to access. There are a couple of disadvantages that we, for the excellent exposure, accept. And the disadvantages are mostly inferior cosmetic outcomes in comparison to more minimally invasive approaches. There's a risk for postoperative respiratory dysfunction due to the violation of the sternum. And there's a risk for development of chronic pain, as well as a risk for development of deep sternal wound infections. Now, minimally invasive approaches, as the preceding speakers mentioned, are essentially defined as we're trying to avoid a full median sternotomy. That is the typical definition. Although I would extend this definition in pediatric heart surgery to minimize trauma associated with surgery. And that becomes important for some of the hybrid approaches that we're going to be talking a little bit about later. So to kind of go through that list, we have the mini sternotomy, and this is essentially an either upper or lower part of the sternum is divided, so an upper or lower mini sternotomy. Then we have a whole list of different approaches to thoracotomies. We have an anterior mini thoracotomy, we can have the anterior or lateral thoracotomy. And we have a procedure that's a little bit, that aims to be very muscle sparing, and that would be the vertical thoracotomy. Then we have a whole subsection of video-assisted thoracoscopic surgeries. And then we have the hybrid approaches and robotically assisted surgeries. So I have marked them in a different color here because the hybrid approaches, as I just said, a lot of the hybrid approaches actually involve a full median sternotomy, which would make it not necessarily a minimally invasive approach. But that being said, some of those approaches allow us to avoid cardiopulmonary bypass. And you might imagine for example, a perventricular VSD closure in a premature infant, avoidance of cardiopulmonary bypass in those really vulnerable and small, low-weight pediatric patients is very helpful. And so robotically assisted surgery has gained traction in adult cardiac surgery, but it's essentially still mostly in the infancy in the pediatric population. And this is mostly related to the limitations in patient size and instrument sizing, although there is interest and there is a continued research into that field. Okay, now we talked about advantages disadvantages of full median sternotomies and advantages of minimally invasive approaches, but are there any problems associated with those? So the biggest problem is essentially the reduced exposure of critical structures. And if you combine this with a small size of a pediatric patient, neonates, small infants, that can result in specific issues for the surgeon. Now, there is also a significant learning curve for the surgeon to basically be able to operate through those small incisions. And that results in, one, a potentially longer surgery and cardiopulmonary bypass time. and it also results in a potential higher risk for injuries to neighboring structures. And another part as a problem for the pediatric population is the fact that some procedures would require peripheral cannulation for cardiopulmonary bypass, and there we are also limited by vessel size. Plus, we have significant higher complications in smaller infants when cannulating, for example, femoral vessels in regards to subsequent venous thrombosis and arterial stenosis and thrombosis. Okay, so let's look at different approaches and the procedures that have been successfully performed with that particular approach. So first, we'll look at the mini sternotomy. And as I mentioned, we can have an upper mini sternotomy and a lower mini sternotomy. The upper mini sternotomy are predominantly used for aortic valve surgeries. And lower mini sternotomies have been utilized for septal defects, so ASD repairs, VSD repairs, as well as AV canal repairs. We have had success with surgeries for tetralogy of Fallot correction. We had mitral valve repairs, and there is the approach to epicardial lead placement, which is mostly limited to the ventricular leads. The atrial leads are a little bit more difficult to access through a lower mini sternotomy. Now, in this picture here, if you look at the right side, that gives you a little appreciation of the anatomic location and the access that would be provided by a lower mini sternotomy versus an upper mini sternotomy. Now, one important part to consider here, in the pediatric population, the lower mini sternotomy is particularly attractive since the upper sternum, the manubrium, is not divided, and that results in the fact that the upper thoracic clavicular sternal joint area is undisturbed, which promotes healing and allows an earlier return to physical activity. Now, the big problem with lower mini sternotomies is essentially the cannulation of the ascending aorta. And so what is required here is a significant traction on the upper part to expose the upper structures, and then cannulation through those. It is possible, and especially it's possible since younger children has less bony but more cartilaginous rib cage, so that allows for actually a good exposure just by traction. As you can see here, that's a pretty small incision. It's about a 3 centimeter incision in a pediatric patient with mini sternotomy. Let's move to the next one. That would be a left anterior mini thoracotomy. And that's a very specific approach that we often use in older children or adolescents for pulmonary valve replacements. As you can see here, the left anterior mini thoracotomy allows a nice exposure of the right ventricular outflow tract. The drawback to this procedure is that it requires bypass initiation via peripheral cannulas. And what you would see here, the surgeons will make an about 5 to 6 centimeter transverse skin incision, about 1 centimeter lateral to the left sternal border. Then you have the retraction of the lung over here. Here you expose the pericardium, and then you can enter the area above the right ventricular outflow tract and perform the pulmonary valve replacement. We recently reported on a series of 6 patients, and our age groups were anywhere between like 13 and 18 years, where we had good success with that particular technique. Now, the next part, the anterior or lateral thoracotomy, allows actually a large amount of procedures conducted with normal central bypass cannulation. So reports in the literature show good results for repairs of atrial and ventricular septal defects, partial AV canal defects, partial and nominal pulmonary venous return repairs. We can access AV valves, so the tricuspid valve and the mitral valve can be repaired through that approach. There is obviously the PDA ligation technique that we use for that, vascular rings. And there is some reports out where shunt procedures have been performed through thoracotomies. Again, an overview of the anatomic location and the anatomic approach in anterior thoracotomy and the lateral thoracotomy. Now, here's a little different approach. Again, with thoracotomies, it's really up to the surgeons where to make the incision and how to modify the incision according to his preferred approach. A nice technique is the vertical thoracotomy. It allows a really superior cosmetic result. As you can see here, the incision is mostly hidden under the armpit. And the other big advantage is that it can be used to preserve muscles. So especially the latissimus dorsi and the serratus anterior muscle, it can be retracted as seen here, and essentially not always need to be divided for this particular approach. Now moving on to the subset of video-assisted thoracoscopic surgery. So again, this is a really nice minimally invasive technique since our incisions are very small. It's just port-sized incisions. It allows the introduction of a camera and the essentially approach to the PDA that can be ligated to that approach, or a vascular ring. VAT surgeries have not really been used for like intracardiac repairs at this point. There is a interest and people are looking at whether cannulation is possible, but again, in the pediatric population, the size of the patient and the size of the equipment is really the limiting factor for those. For PDA ligations, as compared to a typical thoracotomy, the VATS approach has actually shown a kind of a shorter recovery time and a less stress on the patient during the procedure. Now, talking a little bit about hybrid approaches, and this is kind of the interesting part where I mentioned that this is a heterogeneous group of different surgeries, and examples include percutaneous pulmonary valve replacements. So for percutaneous pulmonary valve replacement, which can be done in the cardiac catheterization lab, this is typically a procedure that we do in a lot of our patients with tetralogy of Fallot who are treated with a transannular patch and then over time develop right ventricular dilation due to free pulmonary insufficiency. And those patients can very often, in the later age, as an adolescent or an adult, can receive their valve in the cath lab. But on occasion, there's a problem with the landing zone, which might be unsuitable. So a hybrid approach here would essentially involve a left anterior minic thoracotomy performed by the congenital heart surgeon, who would then perform a PA banding or application, which can help to create a suitable landing zone for the valve, which is still deployed through the percutaneous approach. And then on the other hand, the other two items on the list here, as mentioned previously, still require a full median sternotomy, but would not require cardiopulmonary bypass. And there would be a hybrid single ventricle palliation, during which we would place a PA band, stent the PDA, and then potentially dilate a restrictive ASD. And then per-atrial or atrial septal defect closures and per-ventricular ventricular septal defect closures. And as an example, the latter approach would, for example, be very important in, let's say, a premature neonate that, for example, had a brain bleed, and where we really are thinking twice about even considering cardiopulmonary bypass, once, of course, because of the heparinization and the brain bleed, but also because of the effect of anesthesia on that very vulnerable patient population, plus the added effect of cardiopulmonary bypass. So I would like to move to a couple of two case examples from our institution to just give you a kind of a perspective of what can be achieved. So the first case example would be a 3-year-old female weighing 13 kilograms who presented for a large secundum ASD repair, which was not amenable to device closure in the catheterization lab. This repair was performed by a vertical right muscle sparing thoracotomy. We placed the endotracheal tube. We performed lung isolation with a 5 French bronchial blocker. The patient had a pretty standard line placement of a radial arc line and IG central venous line. We utilized transesophageal echo, and the patient had a right erector spinae catheter placed at the end of the procedure. The procedure was performed via central cannulation with a 12 French aortic and a 16 and 18 French bicaval venous cannula. The procedure was performed under mild hypothermia. Cardioplegia was administered. The cross-clamp time was about 30 minutes. The cardiopulmonary bypass time was 41 minutes. The patient was extubated in the operating room, was transferred to the CV, the cardiovascular intensive care unit. And was actually, the procedure was performed in the morning, and the patient was transferred to the regular floor on post-op day 0. The catheters were removed, the erectospinae catheter were removed on post-op day 2, and the patient was discharged on post-op day 2. Another example involves a 11-year-old female, 28.5 kilograms, who presented for mitral valve repair for severe mitral regurgitation. And that was related to rheumatic heart disease. That was performed also via right vertical muscle sparing thoracotomy. In this patient, we achieved lung isolation with an easy endobronchial blocker. She also had a radial arc line and IG central line placed, TEE, as well as a right erectospinae catheter, which was placed at the end of the procedure. The procedure was conducted via central cannulation with a 515 French aortic and an 1820 French bicaval venous cannula. Same way, mild hypothermia, cardioplegia. The patient required a second bypass run for continuing mitral regurgitation from the neocords. The cross-clamp time total was 91 minutes for the first and 55 minutes for the second run. Cardiopulmonary bypass time was 106 minutes for the first and 71 minutes for the second run. And this patient was also extubated in the operating room, transferred to the floor on the second post-operative day. The catheters were removed, unfortunately, on the first post-operative day due to dislodgement, but showed apparently good effect for pain control. And the patient was discharged home on post-operative day number 3. Okay, so this brings me to the section where we discuss anesthetic implications of minimally invasive approaches. And again, a lot of those anesthetic implications are very similar to the full sternotomy standard approach, but there are a couple of highlights that I wanted to point out with specificity to minimally invasive approaches, but also to our pediatric population. So we're going to go through monitoring equipment, airway, positioning, reduced exposure, and the postoperative pain control. So monitoring and equipment, we typically utilize standard ASA monitors. Then we're going to need equipment for lung isolation. So depending on the patient, a specific isolation device, and fiber optic bronchoscopes. We utilize percutaneous arterial and central venous catheters. We typically try to achieve good peripheral venous access with at least 2 PIVs. We use the transesophageal echocardiography. Then we utilize near-infrared spectroscopy. And at our institution, we try as much as possible to place 2 cerebral NIRS probes as well as a somatic NIRS probe. And especially in cases where we perform peripheral vascular cannulation for a bypass, we often use a NIRS probe on the extremity. And then we'll place defibrillator pads. So lung isolation is a very important but interesting part in our subspecialty. So it is unnecessary, obviously, for sternotomy procedures, but is very helpful in thoracotomy and video-assisted surgeries. This is a table taken from a very, very good article by Lital and Thiem from the Alberta Children's Hospital in Canada, and it's published in the British Journal of Anesthesia Education. And these authors describe various methods of pediatric lung isolation, as well as the requirements and the science behind it. For example, questions of how do I fit my bronchial blocker to the endotracheal tube along with my scope? Do I need to do a parallel technique, or can I do a coaxial technique? With parallel techniques essentially being placing the bronchial blocker through the vocal cords first, and then intubate, and then use the endotracheal tube just for the fiber optic bronchoscope, versus the coaxial technique where the bronchoscope fits along with the bronchial blocker through the endotracheal tube. So this is really highly recommended for, this article is highly recommended for trainees. Now, for our practice, for adults and for adolescents, we utilize double lumen endotracheal tubes, or easy blockers, or a bronchial blocker. If you go to the age group of preschoolers and children, we use bronchial blockers. When we go to toddlers, we may attempt a bronchial blocker. And here's the interesting part: if we have procedures in neonates or young infants, we typically do not use lung isolation. And the reasoning is that surgeons are our surgeon is pretty happy with displacement of the lung during the procedure, which provides good visualization. And the issue that we've noticed is a lot of times when you have a small neonate, one of the few lung isolation techniques that you are stuck with is essentially moving the endotracheal tube into a bronchus. And there the problem is, even if you can achieve lung isolation after repositioning and even after like small movement during the procedure, that tube can easily dislocate back into the trachea. And so a lot of times you spend a lot of time troubleshooting those lung isolation methods, and you add significant amount of time to the overall anesthetic. And sometimes it's really almost impossible, especially in smaller kids, if you have very small bronchi, that you can actually fit the endotracheal tube down. Now, just to kind of an overview, if you use an easy blocker, a 7 French easy blocker, that one fits to a cuffed 6.5 endotracheal tube along with a bronchoscope. And our 5 French bronchial blockers typically fit to a 4.5 cupped endotracheal tube along with a bronchoscope as a coaxial technique. You can again do the parallel techniques with small endotracheal tubes. So just here a little overview. This would be the easy blocker, which we saw from with a couple of the preceding speakers already showcased. And this one has essentially just a double tip balloon. Gets here on the carina, both sides go in the respective bronchi, and then you just have to use the color-coded one to isolate the right or the left side. Double lumen endotracheal tube, and then we have our endobronchial blocker. There's also a technique where you could use, for example, a Fogarty catheter, endovascular balloon catheter to achieve lung isolation. This is a technique that we have done that we're not terribly excited about because those balloons are typically achieving quite a bit of pressure when you inflate them and can result in damage to the mucosa of the respiratory tract. The next part, positioning. So this is something that all of us are very familiar with, but again, in pediatric anesthesia, the same issues apply for positioning. Especially for thoracotomies, there's risk for pressure, compression, and stretch injuries, and the main areas that are involved would be nerves, eyes, ears, and skin. And as you can see here, typical areas that are under higher risk for injury are the common perineal nerve, the brachial plexus, the suprascapular nerve, and then obviously eyes and ears. So good padding, making sure that everything is in neck neutral position, and then the axillary roll should be all part of the positioning considerations. Now, for thoracotomies, depending on the exact approach chosen by the surgeon, so whether more anterior or lateral, it would be important to kind of position the patient accordingly. And another part to pay attention to would be the upper arm in terms of positioning. Now, the reduced exposure, that is something that we as anesthesiologists can't really help the surgeon much with, but the important thing for us to keep in mind is that there's a significant learning curve for surgeons. So typically surgeons who are not very familiar with minimally invasive approaches who start doing those will be facing challenges with exposure, with cannulation, and just with time that it takes to get to the structures they are interested in. So again, longer surgery duration, and that involves anesthesia and cardiopulmonary bypass, and higher risk of injury to vascular enabling structures. Now, the other part here is if significant bleeding occurs, it is typically more difficult to control given the restriction in space, and there is a potential that bleeding might require conversion to a usual sternotomy. And the last part we're going to talk about is post-operative pain control. So in our institution, we use multimodal pain regimens, which involve non-opioid medications and opioid medications, typical combination of acetaminophen, dexmedetomidine, ketamine. We are trying to introduce NSAIDs early on. So typically in procedures, intraoperatively, we do not give those, but in the early post-operative period in the intensive care unit, if there's no major bleeding, those patients typically receive NSAIDs early on. And then in the pediatric population, besides pain control, sedation, especially in the initial phase after the procedure, is often also a very helpful and beneficial approach. So dexmedetomidine is a fantastic agent, giving us a minimal or limited effect on respiration. And then occasionally we add benzodiazepines. And part of the problem is that pain control is obviously the number one important part that we're interested in pediatric patients. But neonates, I always tell our residents and fellows, neonates not only scream or cry because of pain, there are other parts to that equation, and they're not typically able to tell us directly what's going on. So in the postoperative period, sedation is typically part of our regimen and approach. Now, for postoperative pain control, as actually Dr. Sethi already mentioned, so this is in the pediatric realm, kind of a new topic of interest. And for a long time, our sternotomies, we did not think about any regional approaches. There were here and there certain attempts at local wound infiltration that were met with varying degrees of success. For thoracotomies, on the other hand, is a pretty established approach at our institutions to provide pain control with the addition of regional anesthesia, specifically a paravertebral block and catheter or a rectospinal block or catheter. But the new interest moves more towards the question, would those approaches also be beneficial for sternotomies? And this is in fact showcased in the recent meeting, the 2021 annual meeting of the Congenital Cardiac Anesthesia Society, during which there were specific panels and specific talks about regional anesthesia for sternotomy and bypass. And there was even a pro-con debate about regional anesthesia should be part of the multimodal pain management strategy for pediatric cardiac surgery. So in our institution, our practice, as I mentioned, for thoracotomy, paravertebral or rectospinal catheters, and sternotomy is in flux right now. So we're just starting to kind of trial out some of those approaches and see what the benefits for our patients are. And then to just support this with a little bit of evidence, there is very limited evidence for the pediatric population. And if we're looking at those two manuscripts, those all investigate the effectiveness of bilateral erectospinal plane blocks in post-surgical pain after pediatric cardiac surgeries through a midline sternotomy. So again, those use midline sternotomies. The article by Kaushal was a prospective randomized single-blind comparative study in which they had 80 children that were randomized to erectospinal catheters versus no block. And the group found that erectospinal catheters showed a significant reduction in postoperative pain up to the 10th postoperative hour, with comparable pain scores at the 12th hour and beyond. There was a decrease in consumption of postoperative rescue fentanyl, and the group with the block had lower postoperative sedation scores and a lower intensive care unit stay. The article by Roy was a prospective cohort study in which patients that underwent erectospinal blocks were retrospectively matched with control patients. They only had a very small patient population, actually. There were just 10 children investigated. And the group reported that postoperative opioid use at 48 hours was significantly reduced in patients receiving the blocks. But as you can see, the evidence that I'm presenting to you here is very, very limited. So I think going forward, this is an area where additional larger scale studies are needed to actually get an idea if we derive any benefit from regional anesthesia for sternotomies. And this was pretty much all that I have for you today. So again, in summary, the main parts for minimally invasive surgery in pediatric patients, this is a field that's evolving, where we're trying to kind of push forward as more expertise and more equipment, smaller equipment becomes available. And the major anesthetic implications for us are really focusing on lung isolation, positioning, and postoperative pain control. But if we can achieve minimally invasive approaches, this is obviously beneficial for fast tracking and for even like being able to extubate children on the operating table or very early after arrival in the ICU, and reduced length of hospital stay. And for any questions, thank you very much.
Thank you, Dr. Closer, for a very detailed presentation. And we will take some questions and, if possible, some comments right at the end of the session, if we have some time. I will now ask my co-chairperson, Dr. Jayashree, to introduce our next speaker in the session, Dr. Prasanna. Dr. Jayashree, please.
Hello, everybody. At the beginning, I would like to thank Dr. Manjula Sarkar and D.Y. Patil to give me this opportunity to introduce our favorite Ladka, as we call him, Dr. Prasanna Salvi. He's going to speak on the Indian perspective for pediatric in minimally invasive, and as we have all seen, it's in the still infancy. I would say rather it's still in the preemie time level right now. And with the Indian scenario, Prasanna is the best person to tell us something on this. And of course, he's going to add to his Indian perspective. He's going to now take a step forward for the international experience too. Prasanna, it's all over to you.
Thank you, madam. I'll just share the screen.
Yes, please.
Are you able to see my screen now?
Yes, we are able to see your screen.
Thank you, D.Y. Patil, University School of Medicine and ACTA Mumbai. So I think so my job has been done easier by Dr. Benjamin, because all the anesthetic implications remain the same when we are doing a minimally invasive cardiac surgery, and especially in the pediatric patients. So this is just my experience, which I will share. And I would like to thank my surgeon, Dr. Suresh Joshi, for it, because for the data he has given me before I joined in 2006, and for some of the videos and some of the images. So this was initially in the start when we used to have this very big heart-lung machines, and also there were large surgical incisions which were done either through a median sternotomy or a thoracotomy. So they had their own set of problems. Because of CPB, there was a systemic inflammatory response. There used to be renal insufficiency, coagulopathy, neurological and neurocognitive deficit. And because of the large incisions, we used to have a lot of pain, discomfort. There used to be a lot of non-unions, visible scars, which used to form keloids. And eventually also some patients used to come back with mediastinitis. So in 1990, the definition of minimally invasive cardiac surgery was any procedure which was incorporating a technique that eliminates use of a large surgical incision, that is a median sternotomy or a large thoracotomy. But I would now extend it that we even can use it where we don't use a heart-lung machine, or we don't use cardiopulmonary bypass. Sounds weird, but I will come to it. So what are the advantages we have of off-pump is that, as I said, there's no systemic inflammatory response of the bypass, no CPB-related complications. There might not be a need for blood or blood products, less post-op morbidity and mortality. The cost definitely comes down, the surgical time comes down, and especially in infants and neonates where there's a very narrow safety margin. So what are the types of minimally invasive? As I said before, where there's no sternotomy involved, but we do it on a heart-lung machine. So in that we do a mini thoracotomy, that is a lateral or an anterior, and an endoscopic assisted procedures. And as I said, we have also extended this definition of minimally invasive, where we don't use a heart-lung machine, but with a sternotomy, like where we do a single ventricle procedures, where we do all the three stages, like either we do a PA band or a BT shunt, to a Glenn shunt, or even to an extra cardiac fontaine on a beating heart. We have also done a CABG, that is like a Lima to LAD in a 1-month-old child. We do an AP window repairs of pump nowadays, total endoscopic PDA repairs, like especially the small ducts, and also the hybrid procedures like the ventricular septal defects and the atrial septal defects, which I'll come to. So it was the first case before I joined him in 2006, but he started operating in 2009. The first case was an ASD closure, which was done to a right anterior thoracotomy, it was a direct SVC cannulation and a femoral vein and an artery cannulation. And it was ventricular fibrillation was induced and ASD closure was done. We're taking care that there was no entrapment of air in the left atrium. But what we do now, it's a right anterior mini thoracotomy. So we do a 15 to 20 degrees elevation of the right shoulder. The rest of the things remain the same. The endotracheal tube, the arterial line is the left radial line. Usually the arterial cannula is on the left femoral artery. And we take a right IJV. A transesophageal probe is inserted. And so as you say, the skin incision, it is just maybe 1 or 1.5 inch, usually in the 5th intercostal space along the lateral border of the sternum or the mid-clavicular line. And we raise the flap of the pectoral muscles and we enter either into the 4th space or the 3rd space. And in females, we take more care because we protect the potential breast tissue. So what are the technique? As I said, the venous return, we do a direct cannulation, that we do an SVC and IVC cannulation. We do a femoral or maybe do a femoral vein cannulation. And the arterial return is to the left femoral artery. And as I said, the cross clamp which we apply to the aorta is an endoscopic cross clamp, and we do a cardioplegic arrest. As I said, we open, we make an incision, we make the thoracotomy, we approach the pericardium, and we incise the pericardium, and that we put the stay sutures. Because of the stay sutures, we get a very wide exposure. And this is how we do it. So through this, we cannulate the SVC and the IVC. The left femoral arterial is already cannulated. So that is for the femoral arterial cannulation. And as you say below, we take a small incision in the mid-axillary line in the 6th or the 7th intercostal space. And we take out these, both SVC and IVC cannula through this space, as you see in the down figure. As you see in this figure, once we cannulate the SVC and the IVC, we take these two cannulae out through this incision, which is taken in the mid-axillary line. And this is then connected to the cardiopulmonary bypass. So this is where the venous return is come from the SVC and the IVC, and the arterial return is to the left femoral artery. So as I said, what we do is that, as you see, once we are ready to go on bypass, then we give a cardioplegia needle is put through the incision. And what we do is that we put where you see the site for the cross clamp, that is in the 2nd intercostal space in the mid-clavicular line. We make a very small incision, and through that we push in an endoscope or an endoclamp, and then we clamp the aorta, and then the cardioplegia is given. So this is a very large, huge endoclamp which is there. And in this figure, you can see this endoclamp is then inserted into the 2nd intercostal space in the mid-clavicular line. And through this, we clamp the aorta, and then the cardioplegia is given. So what happens is that we get a very huge view because the SVC and IVC cannula are taken from below, and we can get a good view of the atrial septal defect, and we can do either a direct closure or a patch closure depending upon the case. So here we can see a patch closure of the ASD is done. And in cases where you feel that we might not get a sufficient view, what we do is that we put an endoscope, that is, we put a 5-degree scope or a 0-degree scope, and we try to visualize through that and try to close the defect. So what are the congenital anomalies that we have done? We have done all the primum, secondum, even we are doing even the SVs, the one with PAPVCs. We do the PM, the perimembranous VSDs, the partial AV canals. Even in some cases, we have done tetralogy of Fallot, which have isolated valvus stenosis, and even Senning's operation. And adults, I will not get into it because we have done the minimally invasive tricuspid valve, mitral valves, and the LF myxoma. These are not so what we have done ASDs, we have done the perimembranous VSDs, and the AV canal defects. So the brief statistics, so since 1996, we have done over 1,000 cases with just one procedure-related mortality in which we, while cannulating the aorta, there was a dissection because it was a case of Marfan's. And 3 conversions. In the earlier cases, we had to convert from 3 minimally to a mid-sternotomy because they had a VSD. One was a VSD with an aortic regurgitation, and it was in the missed. One was a missed left superior vena cava. but this was all in the earlier cases. So what are the limitations we have? Like we are not able to, so the limitations of this minimally invasive that we might not be able to expose the RVOT or the LVOT. It is only an excellent, we get excellent exposure only in children who are less than 25 kgs. Usually we would prefer a smaller femoral cannulation because of, we don't want to have vascular injuries. And because of this small femoral arterial cannula, we need the flow rate maintained by the perfusionist is usually around 1 to 1.2 liters and usually cannot be done in less than around 8 kgs. So this is a small incisions which we take usually just maybe an inch or a 1.5 inch this. So as I said before, we are now extending our minimally invasive criteria to even where we do our heart, do with a small sternotomy, but with no heart-lung machines. So what we have done where we do the single ventricle procedures, all the 3 stages, the PA bands, extra, then we have done a CBG and an Al-Kappa, that is the anomalous left coronary artery. So that we have also tried to do on off pump for an AP window. And also we have done hybrid procedures like an ASD and VSD, which I'll just go in short in the next 5 minutes. So as I said, we do the single ventricle physiologies where we need to do the 3 stages, the PA bands and the Glenn shunts in the first stage. We do the bidirectional Glenn shunts also off pump in the second stage where a clamp time is usually just 6 to 16 minutes. We monitor the SVC pressure and try to keep it as low as possible. We try to withdraw blood from the SVC and try to give it into the line inferior vena cava. And also we are now trying to do even the extra cardiac fontaines off pump. Because so first what we do is that we take the tube and we connect the upper part of the tube to the right pulmonary artery. So it is only during the lower part of the tube which has to be connected to the inferior vena cava. So this is only the time where we can have hemodynamic compromise. So what we do is that we put a small shunt. So we put a drain tube from the IVC to the RA. That is but we take care that there's no air which goes, because this is all single ventricle physiologies and we have to be very careful. So once the shunt is done from the IVC to the RA, we just clamp the IVC, and just in 2 to 3 minutes we just anastomose the lower end of the tube to the IVC, and it is during this time we find the most hemodynamic compromise. But these hemodynamic compromise don't occur because of the IVC to RA shunt, and we also do other maneuvers like we do a Trendelenburg position and also maybe give a little small vasoconstrictor during that process. It's only during just 2 to 3 minutes that we take care. And we also can do even when we want to put a perforation, between the tube and the single RA, we have also done this off pump. As I said, this is where it is a small. This is the upper tube which we connected to the right pulmonary artery, and it is only during the left, the lower part of the tube, when it is connected to the IVC, which has the most hemodynamic compromise. So this is a finished version where we have done this whole content procedure, extra cardiac content on a beating heart. So now we have also one thing which we have done is now where we have done even a preparation fontaine. This is definitely where instead of 3 stages, now we have converted into a 2-stage, where the first stage is ideally a BT shunt or a PA band, and the second stage is during a Glenn. So this we do it on pump, but we do it like a completion fontaine. Only thing we put a small membrane at the upper end where the tube is connected to the RPA, and we make a very small perforation. And we put some guide, a metallic guide there like a clip, so that it is easier for the cardiologist to do it in the cath lab. And we also put in we make a big perforation in the tube which opens into the RA. So it acts like a Glenn, acts like a Glenn in the second stage. But instead of coming for the fontaine surgery during the third stage, because it has all its complications like redo surgery, what we do is that we just do it in the cath lab. So the 2 things which the cardiologist has to do is that he has to just put a fine catheter which goes in through the membrane, which is connected from the tube to the RPA, and then he has to just break that membrane, and then he puts an ASD device closure, from in the big fenestration which is there between the tube and the RA. So in this way, we then form the Fontaine circulation, and we don't need to do do the Fontaine circulation in the surgical OT, but we do it the completion Fontaine in the cath lab. So this is called as a preparation Fontaine, and this has been, we have finished around 5 to 6 cases. And in these cases, and the major problem in Fontaines is the post-operative drains and arrhythmias. And in all our 5 cases, we have discharged our patients even on post-op day 2 or post-op day 3. While the other Fontaines might remain in your ICU maybe for a weeks to even 2 to 3 weeks. As I said, AP window, where there's a small communication between the aorta and the pulmonary artery. So conventionally, we do a very conventional patch closure on CPB. There we take an incision over the window. But what we have done is now we put clamps, taking care that we are far away from the aortic annulus, and we do it off pump. So we have tried this in all our cases, even in neonates, and we have got wonderful results. So there's no need to put the patient on cardiopulmonary bypass. As you see, this is a big aortopulmonary window. And this is something which is a new cobbler's technique which we have done. So the surgeon just takes a small felt and puts the sutures and goes through the AP window. So this entire procedure is done under T guidance. So he just takes out and through this, when we do this procedure, we see that either the RP or the aorta is not compromised. And we also see for the openings of the coronary ostia, both the right and the left. And also we see that post-procedure, even the RPA is not compromised in this. So there's hardly any, we don't need to put this on patients on pump. And because these AP windows, they have a very high pulmonary vascular resistance because of the increased flow. So we can totally avoid the pump in these cases. One more interesting case is where we have done an Alcapa, that is the origin of the left coronary artery from the pulmonary artery. So in these cases, because the coronary artery is arising from the pulmonary artery, 2 things which happen is that these kids have a very reduced ejection fraction, maybe just around 10 to 20%. And the usual procedure we do is the reimplantation of the left main coronary artery, and and the ligation of this. But what we do now is that so what we do is, as I said, so what we do is that we have now started doing a thing where we have ligated the left subclavian artery, and we have we anastomosis this left subclavian artery to the left main coronary artery, and where the origin is there of the left main from the pulmonary artery, that is ligated. So only issue, so we do it on a beating heart. We have these pediatric stabilizers. So it's like doing it's like doing Lima to LAD. So instead of Lima to LAD, we are doing a left subclavian artery to the left main, and where the left coronary artery is coming from the subclavian, we just ligate it. I'll just see if the videos. So these videos are now. So what we have done, these videos. Let me see if it is working or not. Yeah. So we have done even the angiograms in this, where we can see that the left subclavian is continuing as a left main, and even in all our cases we have finished 10 cases, and in all our cases the ejection fraction, which was just around 10%, is now almost around 6 normal ejection fraction in all these cases. And we have also followed up these cases because since we have ligated the left subclavian artery, we just wanted to know whether there is any discrepancy in the arm. But we have not found any discrepancy between the left and the right arm, and also there has been no discrepancy even in the function of the 2 arms. So we have even so this was also when we had done a left when we're doing an arterial switch operation. We were difficult to come off because there were some ST changes in the anterior leads. So what we decided to do is that we took out the Lima in a 1-month-old child and we anastomosed it to the LAD, and then we could successfully come off bypass in this case. So what I wanted to show is that minimally invasive is not only where we do it through a small sternotomy, but also if we can extend it to cases where, where we try to prevent and the heart-lung machine and try to do these cases without the use of a cardiopulmonary bypass. And the two cases where we did this hybrid was one was an elderly gentleman who was around 68 to 70 years, who had an atrial septal defect and who had a single LAD block. So we did a Lima to LAD on bypass, and we did a transcatheter closure in the in the OT through an incision in the RA. And the other one we had done was through in a ventricular septal defect, a 1-month-old child who was transferred from some other hospital to our center, and he was on ventilator because he had a very large VSD and he was in sepsis, and we couldn't close, the VSD could not be closed because of his septic conditions. So we decided to take all the risk, and we went inside, and through an RV puncture, we decided to close the, we closed the VSD. And surprisingly, we had such wonderful results that the child was extubated after a week, and he went home after almost around 15 days. So to conclude, I would say that minimally invasive cardiac surgery has significant role in congenital heart. So right anterior mini thoracotomy is a very safe and excellent alternative approach, and it can be done through a right atriotomy, especially in children above 8 kgs. And beating heart transplant, as I said, Hoff pump can be applied safely to several congenital heart procedures to reduce the CPB-related mortality. So thank you.
Thank you, Dr. Prasanna. Yes, Dr. Jayasri.
Sorry, Rahul, you can tell the Nancy.
Okay, sure. Fantastic presentation, Dr. Prasanna, and there were many things that we learned from the innovative approaches that you are taking. I guess we have about 3-4 minutes for some discussion, and I would want to ask Dr. Klosel that what would be his advice for pediatric heart surgery units which are starting their pediatric MICS program? What are the kind of teething problems that they can expect to face?
I think one of the major parts for those procedures is really, I think, a good way of a little bit of mentorship through the initial process of going through those surgeries, because I think, obviously a cardiac surgeon needs to go through the process of learning those procedures, but also having just an extra pair of hands or somebody who is experienced. So kind of that from the surgical part, going through that. And then another important part is team training and getting everybody on the same page. So we cannot see ourselves always like, we're in this little island of being in the operating room, but those things extend into the intensive care unit. They involve cardiologists, nursing staff. So basically the whole team needs to be aware of the approach, the limitations, and the specific issues with those minimally invasive procedures. And especially in the beginning, I think, just being aware that while we're doing those procedures to essentially, in the long term, get things done potentially quicker with less invasive and less stress on the patient. In the beginning, thanks to the learning curve for everybody involved, those things can be almost a little bit longer or more tedious. But I think having everybody aware of that and going through the steps, doing a good team brief, good team approach, and having everybody on the same page is important.
Thank you. For years, we have been used to putting a tube and a few vascular access and going ahead with the median sternotomy. We are kind of conditioned for that kind of cardiac surgery. Now, minimally invasive in pediatric is requiring anesthesiologists to use lung isolations, several kind of surface blocks. So, yes, there's a lot of effort on the part of the cardiac anesthesiologist and obviously the cardiac surgeon. Now, do you think, based on your experience of MICS in pediatric surgery, that the real life benefits are worth taking all that trouble?
That is an excellent question. And I think part of the problem as individual providers, we are subject to a lot of bias. And, I can tell you of great success stories where, the patients I presented, I mean, they get discharged to the floor on day 0, get discharged the next day, fantastic outcomes. So looking at those, I would say absolutely. But then I think one of the biggest issues is we need to reach a critical mass, and then we need to really look at outcomes and look at, very objective and designed studies to actually find out is it beneficial or not. And certain things like VATS, for example, PDA ligations that we always have done in small kids through thoracotomies, that introduction of thoracoscopy, again, learning curve, as soon as we have that learning curve behind us, they have been already shown to be beneficial in certain aspects. And I think that's the way to go in the future. When centers have established their routines and feel comfortable, really looking at their outcomes and looking at comparisons to more traditional techniques and how we can kind of improve on that.
Thank you. Dr. Jayashree, if you have any comments or questions to the speakers.
Thank you, Dr. Benjamin. It was a very enlightening and in-depth lecture of yours, and also to know that there is a learning curve. Yes, for pediatric, especially since we are doing the smaller kids, it's a learning curve for all the lines as well. Dr. Prasanna, thank you very much for an exhaustive coverage and your personal experience. My question for you is, what post-operative analgesia, what are you giving?
So we usually use IV paracetamol in the ICU. We usually do not give blocks here at present, but we give IV paracetamol, and we put an infusion of dexmedetomidine, but that acts as a liquid. Yeah. So that acts as a and it is also like given by others like ketorolac and other medications.
Why are you not using blocks that we are so much talking about?
Yeah, because maybe because of my personal because I'm not very comfortable while giving blocks. That's the only thing. Otherwise, it's not an issue. Yeah.
Okay. Thank you. Prasanna, it was very good and it's nice to listen to you always. Dr. Benjamin, thank you Dr. Manjula and ACTA for giving us this opportunity. Thank you very much.
Thank you, madam. So thank you, Dr. Benjamin. Thank you, Dr. Rahul, for that for moderating the session, and Dr. Benjamin. I'll now I invite Dr. Manjula Sarkar, madam, to conclude this webinar. We can't hear you, madam. Madam, we can't hear you. Hello, we can't hear you.
Do the cerebral oxygen saturation monitoring in your institute for all the pediatric patients? Dr. Benjamin, I want to know from your side.
Oh, sorry. Could you repeat that?
Hello, can you hear me now?
Yeah.
Yeah, I want to know, do you do monitoring of all the pediatric patients for cerebral oxygen saturation in your institute?
Yes. So we do NIRS for all on-pump procedures as well as off-pump procedures, minimally invasive. And the only thing that we're always limited is really in terms of placement of the probes in very small neonates. And ideally, we always like to go with 2 cerebral, 1 somatic, and then potentially add a 4th extremity if possible. But at least the minimum that we are using is 1 cerebral and 1 somatic NIRS. Yeah.
So as per your experience, in how many patients you found it was really needed?
Mm-hmm. That's a very good question.
Yeah.
So I think we have had situations where the NIRS was actually helping us. So for example, differences in cerebral NIRS due to aortic cannula malposition, or just limited flow from especially like in certain minimal access procedures where you, for example, go to femoral cannulation and your flows are not as good as in central cannulation. We've seen like decreases in NIRS, and we reacted to them. Now, can I tell you for sure that, it would have, that's the problem. I do not have, the comparison if we wouldn't have reacted, obviously. But I feel that we are making treatment decisions based on NIRS, and we see positive effects to those treatment decisions, which would make me feel that it is helpful.
Do you think it's going to be beneficial even for the post-op management in ICU?
So our institution's standard practice is to keep those NIRS stickers on and monitor for at least the first post-operative day, the first immediate period, and especially in single ventricle children, this is a very this always gets taken into the account to evaluate the overall hemodynamic picture, and in addition to lactate levels, in addition to physical exam, those all integrate to treatment decisions. Yes, so this is definitely, and actually our NICU uses NIRS quite a bit too.
So do you think that cerebral oxygen monitoring may be helpful for cardiac patients for non-cardiac surgery also in pediatric age group?
I think it would. But that being said, I think we all need to be very cognizant of the limitations of NIRS. And so that being said, out of experience, we had a complication in the past with cerebral or neurologic injury that was not picked up by NIRS. Again, based on the likelihood that NIRS is a very superficial kind of technique. So I think that, given recognizing the limitations, I personally would advocate for using it because it might pick up certain things, not 100% of all problems that we encounter, but it might pick up a certain amount that we can correct and we can act on.
Thank you, Dr. Benjamin. And now I would like to conclude all these sessions. Special thanks to Ecta Mumbai and D.Y. Patil Medical School of Sciences, Dean Madam Dr. Surekha Patil, all the international speakers, Dr. Benjamin, Dr. Sudarshan Sethi, Pushkar, though he was doing emergency since last 72 hours and he lost his slides at the last minute, but still he could make to manage his show. And Dr. Dheeraj, Dr. Prasanna, Dr. Sanchita, Dr. Sona, Dr. Sonali Kore, Dr. Salkumar, Dr. Rahul, Dr. Uday Gande for organizing such a wonderful seminar. And special thanks to Sanaya to manage the all webinar internet-related problems. So really thanks to everybody and all the participants to I find out that all the lectures are very explanatory, self-explanatory, and really good for all the PG students and all the students. And apart from the students, I think all the consultants also. So this seminar is really good. Thanks to Prasanna once again. Thank you very much. Prasanna, you want to say something? You are welcome.
I think so, madam. You have said everything. So thank you, madam. And thank you, D.Y. Patil's University School of Medicine to associate with us for this. And I would take this again, as madam said, thank you to all our speakers, especially all the international speakers who have taken the time off, in their busy schedule. To all the moderators, and also to all the attendees, to our MMC observers, Dr. Bijal, I think so. She was there throughout the procedure, throughout the webinar. So thanks to all. Thanks, Shanaya. And to all the delegates also, thank you for attending this webinar. So we will be emailing your certificate to your registered email ID once all our procedure with the Maharashtra Medical Council is done. So thank you once again, and we will close the meeting. Thank you, madam. Thank you all.
Requesting all panelists to keep their video on for a small photograph, please.
Okay. All are on.
Few more remaining, ma'am. Please switch on the videos. Doctor, yeah. Thank you so much, everybody. Just a second. Thanks a lot.
Okay. Thank you once again and goodbye to all, everyone.
Thank you, everyone.
You can close the meeting.
Thank you very much.
Thank you. Thank you.
Thank you. Thank you.